Cases that we show in our courses are cases done by doctors that are in the course or recently graduated from the course. And the reason for that is because, again, it doesn't really help you guys if we just show you like, oh, here's what a doctor who's been doing this for 20 years is doing. It's really helpful if you're like, this is what somebody's in the same boat I am, like somebody who just took these courses, like, this is what I can do. And so we show, so not everything's perfect in the cases, but we learn a lot when we go, okay, so that, how could we have done this better? How could we have done that better? What happened here? What happened there? But then also give you the confidence that, like, these are cases that doctors just like you who are in the course or just graduate from the course are doing. So this is Dr. Lucy Galletly. She works a lot with Dr. McGann, our founder, and he mentors her on a lot of cases. So, and she's willing to send a lot of pictures because we like to have a lot of pictures for our cases, so that's why we show some of her cases. She started with some Clear Correct and then did the comprehensive series, learned how to do braces. In fact, I think she's still in it right now. And then she's also using our progressive aligners now. So this is a 32-year-old patient. I wonder about that. She looks older than 32, doesn't she? Yeah, I think maybe that's wrong. Maybe that's wrong. She looks like she's my age, in her late 40s, early 50s. Anyway, her chief complaint is that she has some crowding and she has some temporomandibular joint dysfunction. If patients come to me for ortho and they specifically are having ortho done for their temporomandibular joint problems, I refer them to a specialist. If they come to me to get ortho done and they have some TMJ problems, and if those get better, great, but that's not their main motivation, then I'm okay treating it. Because most of my patients' TMJ symptoms do get better during treatment. But you say no? Oh, that was your phone. I thought you said no. No, you're good. So most of my patients' TMJ symptoms improve, but if you're really doing ortho to fix your TMJ, I'd rather you be with a specialist so that, not that they're necessarily going to do anything better, but that way if you're not happy with the results, you're not suing me over it. So that's why I do that. But she's mostly concerned with her crowding. She's resistant to IPR. She's heard about making her teeth smaller, and she doesn't want to shave off her teeth. Oh, so what's the first thing we do when we look at a case? Face profile. Is that a straight, convex, or concave face? A little bit concave. So does she need more lip support, less, or leave it the same? A little bit more. I mean, definitely we wouldn't want to give her less. So whatever we find out in her mouth, we're not going to want to see her teeth retract from the start position. It would be good if they went forward. What about her dental midline? Do we need to shift that left or right, or are you guys okay with it? So our reference point usually is Cupid's bow, is the tip of, right in the middle of Cupid's bow. She's pretty close. So if it went a little bit, it almost looks from where I'm standing like it could, it's hard because her tip of her nose is off a little bit. But it could go this way a little bit, maybe to her right. Is that what you guys are seeing? And then what about the vertical? Just at least what you see. We don't have a resting lip photo here, but when you see her smile, does it look like her incisor needs to go up or down? Or because the other thing we look at is that lower lip line. You know, and we don't want that to be below the lower lip line, but we also don't want to be way away from it. Hers kind of follows that lower lip line pretty well. So from a vertical standpoint, she looks good. From a midline standpoint, she looks good. If it shifted to her right a little bit, that'd be okay. More than anything, we want to make sure we don't bring it back, and we'd like to advance it a little bit. So knowing that about her face, that's where we start, because then whatever we see in her mouth, we want to try to make sure that how we treat it complements what we decided before we looked at her teeth. Okay? So when we look at her mouth, this is what we see. So from this picture, what do you guys see in this picture? What grabs your attention? Lower midline compared to upper. So a little bit of a deep bite, okay? Because we'd like to ideally overlap these bottom teeth by about 20%, and this looks more like maybe 60%. It's not a horrible deep bite. Probably not a horrible bite for an aligner case, but she definitely tends a little bit deeper, a little bit stronger muscle. Say again? Yeah, it's difficult in this. Well, this picture is a little bit better. When we take pictures of the posterior occlusion, we want to be at the same angle that we would open up the contacts on a bite wing. If we come too far forward, which a lot of times in the pictures, we're positioned a little bit too far mesially, and when we're positioned here, it makes it look closer to a class 3 bite, whereas if we swing around and look at it at the right angle, it might be more class 1. So we'll see what that looks like on the actual model. But you're right, in that picture, it looks a little bit class 3. Which arch has more crowding? Looks like the lower has more crowding. Would you guys, if you were doing aligners, would you want to get a disc out and create nice looking incisal edges before you started aligners? I like to clean it up because you have a technician who's there trying to decide how to position your teeth, and if you have ragged anatomy, it's kind of like, well, where do you position that? So when I see anatomy that's all ragged like that, I like to go and take a little flexi disc and just kind of level that a little bit. Sometimes, especially in lower incisors, you'll see like pitting, where you have these unsupported enamel around the edges, but then there's a loss of dentin in the middle. So instead of just grind off all the enamel down to the dentin, I'll actually just use a little round burr, slow speed round burr, and clean out. They don't even have to be numb, just kind of clean out that little pool, make sure there's no dentin that's kind of soft in there, and then etch it, and then just put a little bit, etch and bond, and then put a little bit of flowable composite in there to kind of fill that little pool up that has 4 walls on it, and then take a disc and kind of flatten that on the top. And that will actually support that pretty well. But if you have a missing wall, then it's a judgment call as to whether that bonding that you're going to put in there is just going to fall out at some point. And so we have to make treatment decisions about, because you guys can see here too, well, a little bit more obvious in this picture than this one, but sometimes you'll have a tooth that's really worn down and the gingival architecture is different. So like one has a high gum line and the other one has a low gum line, and you're like, well, am I going to prioritize the incisal edges to be straight and finish with my gum lines off? Or am I going to get the gum lines the same, and then that means one of the teeth has to be ground down or one of them has to be restored? So we make those decisions. So I look cosmetically before we start the case and go, can I idealize the anatomy? Sometimes you'll have a canine that's super sharp on one side and then flat on the other side. And that's hard to make that look good. So I'll flatten the one that's super sharp. But trying to create symmetry and idealize tooth shapes before you start putting brackets on or before you start an aligner case is really nice. If you don't do it, then when you go to do a revision, Dr. Park, you can go and say, now that my teeth are getting closer to being straight, maybe at a revision scan, we'll do a little bit of tooth anatomy, idealizing the tooth anatomy before we scan for the revision, so that the technician can really start to make edges look nice and get things cleaned up. What about the gum tissue? Does she have gum tissue that concerns you? If we wanted, because we're going to have to advance her lower incisors to fix that crowding. And her face said we should advance her teeth, right? Because it was a little bit concave. Can her gums and her bone, from what you can tell, does it look like that she can support having some advancement of her lower incisors? I think so. I think she has nice looking attached tissue, and it looks like there's some bone there. We'll have to look at an x-ray. Maybe a teeny little hint of some recession right there. It's hard to tell in the photo, but I mean, overall to me, I would say she doesn't look like a high risk of recession, and she would look better if we gave her more support. Going back and looking at her smile, if this is all the higher she can smile, and I can't see her gingival architecture, I'm going to prioritize her incisal edges with no restorations and let those gingival heights be off a little bit, because you'll never see it on her. But if she's one of those that smiles and you can see all of the gums, then I might prioritize the gums, make those look symmetrical, and then put a little composite on one of the teeth or take off a little bit on one of the teeth. So these are decisions we make as we're planning the case, because we have to make that decision before we start, not at the end of the case. Okay, and that's what you have when you look in the mouth. Not very much crowding in the upper, huh? So not much is going to change in the upper, which is a little bit sad because we wanted a little bit more lip support. And then quite a bit of crowding in the lower, which I don't know what her overjet looks like yet. So maybe she has an overjet thing where when I fix the lower crowding, her overjet gets correct. If her overjet's good right now, and I don't have any crowding in the upper to really advance her teeth, then in the lower, I may have to do a lot of IPR or something to get this to coordinate. So we'll have a look at it a little bit closer when we look at the models. Do you see any severe rotations, any teeth that look real severely rotated? Not too bad. This is actually a case that I feel like, you know, you could probably do with an aligner. There's a lot of, like that crowding would get resolved faster with braces, but it doesn't look like something that would be impossible for me to do with a aligner, because really rotated, really tipped teeth, those are hard to do with an aligner. If it's just a matter of pushing teeth to the buccal or lingual, that works pretty well with an aligner because it has that big flat surface on the buccal lingual to push on. Okay, so again, I haven't gone through all of these with you guys in this course, but I would say, well, what do you guys say? How about facial profile? Where would she fit on facial profile? So somewhere maybe in this yellow area where she's not horrible, but she's a little bit retruded. Are you guys seeing my pointer? Yeah, okay, so somewhere around here. Face type, she's more brachyfacial. Okay, she was the more strong muscle, kind of compressed, kind of concave, so strong muscle, so kind of in the yellow zone over here as well. Her upper dental midline, we thought was pretty close to green, maybe going slightly yellow towards her left side, because we said it could move a little bit to her right side. Upper incisor edge to the resting lip, we didn't have a picture to show that one, so we don't really know, but we said that probably is in a good position where it is. She definitely does not have excess gingival display when she smiles. She did not have lip strain to close. We would click those boxes if she did, because then we'd have to take those into consideration. Upper incisor inclination. Kind of hard to see in that picture what the inclination of the incisor is. One of the photos that we take is this one right here that shows this smile from a profile view, and it's kind of hard with the lighting to see there too. But do you guys get the sense that her incisors, let's look at the model. Do you get the sense that her incisors are like kind of tipped back, or are they kind of tipped forward? That's kind of what I see too, a little bit back. So if I was filling out this form, I'd say her incisor inclination would be kind of over here in the yellowish green for retroclined, kind of tipped back, which again tells me it's okay to move them forward for her. Her gingival tissues in the anteriors looked nice. I'd probably be over. This one's interesting. We kept the same color, but really you're going from thin, which is red, to green. You know, thick would be green over here. But there are some cases where actually patients have too much thickness. You guys seen like gingival hyperplasia, and sometimes when people have braces on, their gums get super bulky and thick. So anyway, she'd be kind of a nice green for tissue thickness. In the posterior, you know, we haven't spent a lot of time talking about this, but we'll also, if we're going to consider expanding, like on this patient, we really wouldn't consider expanding much because she doesn't have any crowding in the upper. And if I expand in the upper to give her a broader smile, what is that going to do to her slightly tipped back teeth with her not enough support to her lip? Yeah, because I made space by expanding, so then it's going to be harder. So I'm probably not really looking at expanding her very much, but if I were, we would also want to look at the tissues along the buccal to see if she has any thin bone or thin, recession on that side too. Because if you're considering expanding your patient, you want to make sure that you have healthy tissue on the lateral and the buccal side in the posterior as well. So that's why we've put that on this form right here. Anterior overjet, haven't really seen a picture of that yet. Arch length has to do with spacing and crowding. She's more crowded. And then in the vertical, we said she was slightly deep. She definitely would be okay to advance her teeth. Not great to expand because we don't want to take away her lip support. So now you can see the bite a little bit better. So from this view, class 1 would be when the mesiobuccal cusp tip is slightly behind that buccal groove and the distal marginal ridge is touching the 7. So on her right side, she's a molar class 1. And then because each tooth has a slightly different angulation, you can go, well, that bicuspid has a little bit mesial crown tip, so it's a little bit class 2. That tip should be right there. That one looks more class 1. That canine's a little bit tipped. But once I straighten all those teeth, if the molar was class 1, all that other stuff will just interdigitate really nice. So she's good on her right side. Now, on this side, we're coming a little bit too far from the back. So it's still not an ideal angulation. So you saw it too far from the front the first time. Now it's too far from the back. But I think you can pretty much still see that there is contact there. So she's basically class 1 on both sides. So this is an easy case because the easy part is she doesn't have to do any fixing of her bite. She just straighten the teeth. But then there's a couple little things that are challenging, a little bit of yellow. You know, there's a few things about her that is challenging, the little deep bite and the crowding. You can see how she's imprinted her bottom teeth onto the back of her upper teeth. The wear patterns that she's got going on there. What about those lower incisors? Now that you see this view, those have got worn off at all different angles. So when you go to make those all straight, you can't make those straight where the roots are all straight and have the incisal edges look right. So at some point, whether it's now or later on in the case, we're going to have to make incisal edges be perpendicular to the long axis of the tooth so that when the teeth are straight, the incisal edges look straight. It's part of ortho. We have to, if teeth wore irregularly, we have to also either restore or wear off some other parts of the tooth until things look correct. There's the overjet picture. Does she have excess overjet or insufficient overjet? What do you guys see on that picture? Yeah, it looks kind of ideal right here between that central incisor and that lower central, but then there's definitely excess there and maybe excess at the canine. So it looks like her lower canines maybe could come out a little bit. So we're going to be able to eat up some of the crowding in the lower by just filling in those areas where we have too much overjet, but there's not a ton of overjet, so she may end up needing some lower IPR. Okay? She didn't like that. That's right. The other option would be to try to bring her upper teeth forward. So even though she's a class 1 molar, if she doesn't want to do IPR, but I want to get her overjet right, then I have to use a class 3 elastic to bring her upper teeth a little bit forward and finish a little bit class 2 in the back. Here's what her curve of SPE looks like. It's not severe, but it's still something that we're going to want to level during treatment. Here's her panoramic x-ray. Looks pretty healthy. Now you can see the ceph. Now, ceph is not something you guys are all used to looking at. So when you guys look at the ceph, what do you see just looking at that ceph? Why don't we look at tooth inclination? We kind of got an idea by looking at her models, but what do you see when you look at her ceph? Do her teeth look like they're tipped backwards in the front, or do they look like they're proclined out? These look a little bit pushed back to me. When you look at ideal angulations of teeth, this tooth angle should be kind of pointing behind the orbit right here. Not horrible up in the top, but it's definitely a little bit pushed back, and that lower one really looks pushed back to me. It's just kind of flat through the front. And without doing measurements and stuff, just eyeballing it, can you guys see that the plane of her maxilla and the plane of her mandible is more parallel? The further they get like this, the more that's one of those dolicho patients who has weak muscles. The more that those lines become parallel, that's more deep bite. That's more strong muscles. And you can see she has more of a 90-degree angle here. So she's not a severe brachyfacial patient, but she's definitely on the stronger muscle side, which means her bone's going to be a little bit more dense, which means the aligners are going to be a little bit harder. Her teeth are going to move a little bit slower. Might take a little bit longer. Yeah?
Does she complain about airway problem?
About what problem?
Airway?
Airway? I don't know. But I'll tell you, in cases like this, she did have some TMJ problems, and where she has a little bit of a deep bite and everything looks pushed back, when you start to actually open things up, their jaw actually kind of comes forward a little bit and frees up because she's kind of trapped. She's a little bit like stuck. And they start feeling better as they go, aligners or brackets, they'll start feeling better as you start to get rid of that trap of the incisors holding the jaw back. There's a great TMJ evaluation in our SmileStream software we won't go into right now. This is what it looks like when we work up cases in SmileStream. SmileStream is you can find it online if you want to go look at smilestream.com. It's a software that we've developed before we came up with this one with Medit. It's way more complicated. We teach it in our full series. We'll teach you how to use the software. But before we had the 3D simulations, this is how we worked up cases. We would trace the lateral ceph, and we did this not by hand, but we were clicking on things. It took a lot more time than the automated one. But we get a full bunch of data out so that we can compare this patient's ceph data to norms to try to figure out where they're off in the ceph data. Then we place all these points on this model to actually measure all these teeth. Remember in the other one, the Medit one, it paints the teeth so it knows the size of the teeth. This one, we actually had to tell the computer how wide each tooth was by placing points as we go through. So it took longer to do this, but we still teach it because it still gives us valuable information on more complicated cases. But it takes this information, the tracing, and this information, which tells the computer how big the teeth are, and it combines it together to give you this visual treatment outcome, this VTO. So earlier we looked at a case where the visual treatment outcome, the VTO, was a 3D simulation. This is a 2D simulation showing that that lower incisor is going to have to go from the position in blue to the position in that red in order for those lower teeth to get straight based on the crowding. So we're seeing the same problem, right? Just a little bit of advancement of the upper because she doesn't have very much upper crowding and a lot more in the lower. So either we have to do IPR in the lower arch, because see the collision? Or we have to try to bring all the upper teeth more forward to get this upper tooth more forward, which would be like a class 3 elastic. Or we could maybe restore her upper laterals to be bigger, so that there's more tooth mass in the upper. But she's resistant to IPR in the lower. Maybe we have to talk her into it. So what else are we going to do here? But this is how we used to work up all of our cases, was in this 2D. And now we have this other software, which is a little bit faster and easier and gives us a 3D VTO. So in the new software, I'm not going to show you these because we can just show it to you in the software. So let me actually go show you this case in the software. Which case number was this? Number 1463. So I'm going to open the case that's already worked up just so we can save a little bit of time on the steps. So remember, we already put those 4 dots that made this occlusal table. We already got the teeth painted and numbered correctly. The ceph was traced. So there's the ceph. The model was oriented onto the ceph. And we got 2 green lights. So in the skeletal AP, her bones relate well to each other. She's class 1 skeletal. And in the vertical, it gave us green. But if we look at it, we're kind of right on the border of yellow right here. So we all felt that she was a little bit skeletal closed. Okay, so she's measuring average, but on the closed side of average. Then we picked the arch form that fit, and we picked a medium ovoid. You can kind of see how it's hitting right along the base. This one's a little bit constricted, so I would expect to see this one kind of advance those lower teeth a little bit more because it's a little constricted, but we have an option to look at an expanded plan. So we'll leave it like that. So medium ovoid, upper and lower. The bite classification was set. You can see how it came up with a slightly negative number, but it's still giving us class 1 simulations. If I want to see the simulation that's going to be the class 3 elastic, I have to click on the class 3 plan. So the simulations look like this. See how there's an insufficient amount of overjet here? But let's look at what aligning her teeth does for her face. Is that what you guys want based on her face? She needs lip support, right? Because look at my other options. I can expand. So, oh, that's the expanded one right there. Here's the non-expanded one.
Excuse me.
Yeah.
Didn't we trap the lower jaw further by expanding the anterior teeth?
Yeah, that's why I was like, wait, this doesn't look right. So the non-expanded one right here shows what we really want, which is advancement of the upper and lower. Okay?
She already had a little bit of BNJ.
Right, because if I go to this expanded one right here, you can see how the upper is actually coming back a little bit from the start position, which is not great for her. So we're not going to be expanding her.
I know she's not going to like that, but one of the anterior, extracting one of the anterior to give her more healthy and BNJ, I know it's going to be further.
Taking out one of her lower anterior teeth?
I know she's not going to like that.
Well, you know what? Look at how easy it is to look at that. So here, let me show you first what we have just with alignment. Okay, so let's look at the lower arch. Here's what just alignment looks like. So you can see the advancement to get those teeth straight, and she doesn't want IPR. And you're like, well, would you rather take out one whole tooth, or would you rather take off a little bit off of all of the teeth but leave them all down there? Because that gives probably too much advancement for her, because it doesn't give us enough overjet. So watch, if I go back here, and I just say that one of these central incisors, let's pick number 4-1. I'm just going to say that that's going to be an extraction. And then I click back over here. I can actually see the case with that tooth extracted. There you go. It's no longer trapped, but she also has too much overjet now. So if you look at the case, let's look at the lower arch. So there's the tooth extracted, and then we fix the crowding. Okay? Great, but to me, that's now too much overjet. So if it was me, I'd rather talk her into IPR and not do a tooth extraction down there. So let me go back and get rid of the tooth extraction.
So how much IPR? Like 2 millimeters on each side, maybe the distal of canine?
Yeah, if I went distal of canine to distal of canine and I went 0.3 millimeters per contact, and that should be 7 contacts, that would give me 2.1 millimeters of tooth mass reduction. And well, that total. But I could go up as high as 0.5 millimeters per contact, which would give me more like 3 millimeters total.
So here is about 3-4 millimeters.
When I take out one lower incisor, that's about 5.5 millimeters. Yeah, that's how. The average lower incisor is 5.5 millimeters wide. Let's see how wide hers is, because look what I can do. I can go to, well, let me clear this. And let's go back. But lower incisors generally, lower central incisors are generally about 5.5 millimeters, and a lower lateral incisor is about 6 to 6.5. So if I turn on the grid, let's see how wide hers is. There's a grid right here.
You can measure.
Her lower incisor is, there it's a 1 millimeter. Hers is 1, 2, 3, 4, 5.5. Yeah, so 5.5 millimeters. So IPR, I would do more like 2 to 3 millimeters instead of 5.5 millimeters.
So do you use power chain to close this space, or how do you?
If I'm doing braces, then yes, on her case, since I want those teeth to come back, I would use chain to close that. If I wanted to do IPR but bring the back teeth more forward, then I might use something different, or I might put the chain on different teeth. But generally, if I do IPR, I'm using chain to close that space.
So if you use a power chain, all those teeth are going to go you out.
They will retrocline, they will tip back, unless I pick, so in our system, we have a variety of torque in our brackets. If I pick a bracket, and that's part of the SmileStream software, if I pick a bracket that when a 19 by 25 wire is engaged into that bracket, it only allows the tooth to tip back to a certain spot before it engages the bracket, which I have a template to tell me. Then I can chain the teeth and pull them back, but it can't tip. It has to move bodily back because I have a bracket wire combination that's saying the tooth must maintain this angulation. So if it's going to be pulled back, it has to come back bodily instead of tipping. But if I have a smaller wire or a round wire, then they would just tip back. 19 by 25 stainless steel combined with a lingual root torque bracket. Yeah. Great questions. I love it. Okay, so here we've got that lower incisor back again. We have too much lower, or not enough overjet. So if I go back over here and click class 3, I'm going to reduce these values down a little bit just so I can show you the IPR and just the lower arch. So I want to make this kind of close to 0 so we don't get a lot of correction from a class 3 elastic. If I choose the IPR in the class 1 case, it applies it to both arches. If I choose IPR in a class 3 case, like I've said this one is, it will only apply it in the lower arch. So I have, whoops, I didn't make it class 3. Class 3. Now I can come in here and choose a plan that has got IPR. And it also has class 3 elastic, but because I set the values at almost 0, there will be very little effect from moving the teeth forward. It's mostly just going to be IPR applied to the lower. So see how now when there's IPR to the lower, it gives us better overjet in the front? And looks like that. So we didn't lose lip support in the upper, but we freed up her mandible by doing so. I know that what I want to do with this case, if I'm going to send it to an aligner company, is I want to straighten her teeth with no expansion. I want to do lower only IPR, and I might even want to add some class 3 elastics. Because with an aligner, if I create those spaces and then I start pulling those teeth back, there's a chance that as I pull on these front teeth, what are the anchors? They're the back teeth. So as I pull the front teeth back, the back teeth could actually come forward at the same time. Probably not in her because she's a real strong muscled patient. But if I had more the dolicho patient and I was afraid the back teeth would come forward, then I would have them make little cutouts in the aligner so that while I'm closing up those spaces, I could have her wear class 3 elastics, which means it's going to be basically a class 3 elastic goes from lower canines to upper molars. And so I'm anchoring her lower posterior teeth to her whole upper arch. So as I start to close those spaces, her lower teeth come back instead of her back teeth coming forward. So little things we do to plan as we're planning this out. But now instead of just sending it to an aligner company saying, hey, straighten the teeth for me, and trusting that the technician is going to do it the right way, I already know what I need to do to preserve her profile, maybe even improve it, and make sure that I'm treating this case the right way. And maybe the way that I get her to accept IPR is show her that I either have to take out a lower tooth, or better would be some lower IPR. And if she's still completely opposed to IPR, then I'm going to rely on class 3 elastics to try to get her upper teeth to come forward as much as possible so that I can do it with no IPR. But then her bite's not going to finish class 1. Little things. She's not a hard case. These are just little things on this one. Her saying she doesn't like IPR is probably one of the more challenging ones. But you know what? Patients change their mind when you educate them. You're like, look, you've got how much? 2 millimeters of, or maybe not 2, maybe you've got 1.5 millimeters of enamel on the surface. We're going to take away 0.2 of that. It's hardly anything. And it's a surface that doesn't ever wear down. It's not something you function on, so it's not like you're going to take away something and have less to wear down. It's no damage that's going to have any problem. And they're, okay, we'll do it. All right, so go back and see what happened with this case. So at this point, we could treat this one with brackets or aligners. Okay, so diagnosing the case doesn't change. We always diagnose the same way. And then we decide on what kind of a appliance we want to use. Got stuck to the chair. Okay, so I showed you this one live, so we won't go through all of those slides. When this case was sent to the aligner company, here are the instructions that were given. And some of these instructions, all of this was done, I think, when this doctor was using ClearCorrect, and we used to have to write out all kinds of instructions. Now that we use progressive aligners, we have a lot of this just preset so that they always do it this way. Move the upper midline 0.5 millimeters to the right, and then they felt like the upper and lower could be synchronized by the time that, basically it's like the lower's in a good position, so shift the upper a little bit. We talked about that when we looked at the case. Buccal crown torque and expansion of lower posterior teeth, especially lower canines. Do you remember when we looked at the model, I showed you guys that like at the canines, there was a little bit more overjet. So by doing buccal crown torque, that's the same as saying push the crowns of the teeth out to the buccal. So it's basically saying, since we have all this crowd in the lower, anywhere that we have excess overjet, lower compared to upper, push the lowers outwards so that you end up with ideal overjet all the way around. So that's one way that we're going to eat up that crowd in the lower. So we're pushing out the lowers. Add 10 degrees of labial crown torque to upper central incisors and lateral incisors to accommodate lower incisor advancement. No IPR. So no IPR in the upper arch. But remember how we said her incisors are kind of tipped back a little bit? Well, if we want to free up her occlusion, if we have crowding in the upper, the crowding will naturally advance our upper incisor. It has to go forward to let the teeth get straight. But in her case, remember that one picture I showed you where her upper went forward just a tiny bit, but her lower went forward a lot more? She doesn't have the crowding in the upper to give us the torque. So we can ask the aligner company to try to give us 10 extra degrees of torque. So literally take a tooth that's like this and torque it, meaning the tooth's not really going to like move bodily. It's just going to torque it out. Okay? Hard to do with an aligner. That's easier to do with braces. It's easy to do with an aligner if we're just pushing the crowns out, but that's going to open up space. But keeping the spaces closed, but getting the roots to go back, that's hard to do with an aligner. If we choose the right brackets and the right wire, we can produce some torque in the teeth. So it's a good thought, and you'll probably get maybe out of a 10 degree, since the plastic is flexible, if they put 10 degrees of torque in the tooth, we might get 3 or 4 out of the case. So it's good. It's going to help us a little bit, make her look better, and kind of give her more room for her lowers. Level the curve of SPE. So that curve that you guys saw, we're going to try to level that curve out. Separate the contact points. This is a great thing to keep in mind for those of you already doing aligners. One of the reasons why rotations don't fix well with aligners is because there's little micro collisions between the teeth. So 2 tricks are, 1, make sure that you're always using a little interproximal strip and make sure your contacts are really light in aligners so that there's no collisions in there. But 2, ask them to, whether it's 0.1 or 0.2, this is one of our protocols with progressive aligner, is they always tilt all the teeth outwards a little bit to open up some spaces so that the teeth can get the rotations corrected without little collisions in the aligner. So that's what this is saying, is, you know, we have some rotations to fix, so. And then because aligners have weakness, they're just made out of plastic. When there's rotated teeth, we like to overcorrect those. So instead of just getting them straight, we want to go like 2 degrees or 3 degrees further beyond straight so that the tooth actually ends up straight by the time we're done, because there's insufficiency in the aligner. Extralingual root torque on one of the lower incisors where the root was back a little bit, and then add attachments. All this stuff, there's a lot of information here. That's why you guys come to class in the full series, because we go through all of these things, why they matter. This is just to get you a little taste of it, okay? But which attachments? Why are they used? How are they placed? What do they do? So this was the setup that was approved. You can see the attachments on the teeth. You know, attachments are just extra bits of composite to increase surface area. It gives surface area for the aligner to push on. This patient has got pretty decent clinical crown height, which is nice. So even with the attachments, you know, if we were to use fewer attachments on this case, which some patients will request, then I look at the size of the teeth, and if they have bigger clinical crown height, then maybe we can get away without the attachments. The smaller the clinical crowns, the more those attachments are really important, because they're adding surface area. See the problem with the lower incisors? See how those were not corrected before the setup was done? And so you're like, yeah, the teeth are straight, but like that's definitely not straight. So you either do it before the case or you'll be doing it after the case or at a revision or something, because you can't take unevenly worn edges and get them to look nice when you align the teeth. And same thing in the upper, you see the irregular edges. You know, to make that look nice, you either had to idealize that tooth anatomy before you started or when you do a revision. For those of you guys who don't know what revision is when a patient's like all the way through their set of aligners or almost all the way through their set of aligners, and then we'd take a new scan and kind of like restart the case. It's getting a new set of aligners to finish up the case. We do it on basically every aligner case because it's like golfing. It's like you rarely get a hole-in-one where you get exactly what you wanted on your first swing. So when we do aligners, we usually plan on having to do a revision or two at the end to kind of get everything finished up. This is what the setup looks like. Have you guys, some of you have probably never seen a ClinCheck setup, right? I've never seen what an aligner setup, because so you send this into the aligner company, so you send them STL files, you send them pictures, you send them instructions, and then they send you back a ClinCheck or a setup. This is a setup from Progressive Aligners. It looks similar to what Invisalign does with their ClinCheck, so let me show it to you. So we're using this to see if the technician did what we asked them to do, and if we like the way that it all worked out, and if we want to change anything. Now, all I have here is a recording to play, but generally when I go and I analyze these, there's a little play button down there, and if I click play, it just slowly goes through all the different stages. And I don't really like that because it's hard for me to visualize the amount of change happening when it just goes really slow. Everything looks doable. Like I could expand the thing a whole lot, and as long as it goes slow, it all looks normal. But when I can grab the little slider and make the movements happen more fast, then my eye starts to see the things that look unreasonable. So I'm going to kind of try to duplicate that here. So I'm moving a lot faster so that my eye can visualize the movements happening. But you guys see how there's, here, let me slow it down. Look at the upper arch. Let's go from right here. So watch the upper arch. Do you see how there's some expansion happening in the upper arch? Watch those bicuspids on the upper left side over here. And it makes sense because you see how when you actually look at her, do you see how on this side, this all looks like it's tipped in a little bit compared to that side? So that's actually just kind of aligning those teeth. It's not like true bodily expansion. It's just kind of like making the teeth not disappear behind that canine. So even though we didn't necessarily want expansion, just making the teeth look straight actually requires some uprighting of those upper bicuspids. What else do we see happening? So a little bit of upper expansion. You can see some rotations getting fixed. Do you guys see the little numbers and how they light up at different points? That's IPR. So she obviously got talked into doing some IPR. If it was me, I wouldn't want any IPR on the top. So if I was redoing this today right now, I would say no IPR on the top. I don't know if they put that up there to be able to shift the midline a little bit. Probably it was to shift the midline. But to me, I would have said no IPR on the upper because I want all that tooth mass in the upper. But definitely some IPR on the lower. And you can see how it is lighting up at different stages. So right at the very beginning, see how one of those is turned blue? Right here. That says that at that stage, when you deliver that aligner, they have to do IPR right there. And then later, as the teeth get straighter, because we don't want to do IPR on teeth that are all crooked, because you'll cut the wrong part of the tooth. So later, when the teeth are more straight, then the other areas of IPR are going to be done, when those contacts finally get in line with each other. So this has got 21 stages. You can see how the deep bite is getting fixed. Remember we said we really wouldn't want to intrude our upper incisors? Can you guys see which incisors are getting intruded? It's those lower ones, right? The upper kind of stays where it's at. And then we look at it from all different angles. So here's what it looks like from the overjet view. And it kind of finishes with a lot of overjet, more than I expected. See, what's hard here is you don't actually have the patient's ceph to overlay this on. That's why making these decisions beforehand is really important. But what I do have is an overlay tool. Remember how I could click a button in my software that would turn purple where they started, and then you could see where it moved from there? You do have that in this software. As you can still see, like, turn on the overlay, or the superimpose, they call it, so that you can see where it started and where it finished. So you go, no, that's pulling this back too far. I don't like that. Looking at it from the left and right view, you can see the movements that are happening. I'm going kind of fast today. There's a lot of things that we can talk about. Look what's going on right here. This is really interesting, guys. What do you see happening on this upper left side that we hadn't talked about yet? Can you see it? Watch right here, right in between those two teeth. You see that space open? Where did they get that space from? Yeah, watch the front teeth. You see how they push the front teeth out? Well, what happens when you push front teeth out if you don't have crowding? You get a space. So what are they doing with that space? Watch that space closely. Watch the space and see what's done with it. What did they do with it? Did they move every single tooth sequentially up until they close it? Now that, if I really wanted that to happen, which we said was a possibility, how would I really make sure that that were to happen? I would want to have those class 3 elastics we talked about. Because picture this. You have a button right here on this canine, and you have a button up here on this molar, and you have an elastic going back and forth between here. And every time the patient puts the aligner in, they also put that elastic in. So now go back and watch the movement, and picture that elastic in place. Whoops, let's start right here. So here you don't need the elastic, but starting right about here, do you see how as we move those upper posterior teeth forward, what's going to make sure that they come forward is adding an additional force to make them come forward. Because as I'm pulling them forward, they're also pulling back on the front teeth. I don't want the front teeth to come back. I want them to come forward. So if I was to add an elastic from here to here, that increased force would change the anchorage so that my anchor for the movement is coming from the bottom teeth rather than coming from the top teeth. So we talk a lot in our courses about anchorage planning. How are we going to plan our anchorage so that we get the movement that we want? Because everything has, anytime that we apply force to teeth, there's an equal and opposite force on the other teeth. So if I'm pulling forward on a back tooth, there must be some tooth in the front that's feeling a pull back. So unless I'm putting in bone screws or headgear and using an external force besides teeth as my anchor, if my anchorage is always just teeth, then when I pull this tooth this way, there's something feeling an opposite force the other way. But then when I put elastics in from one arch to the other, I change the anchorage. And I took this molar and I made it have a gigantic anchor, pulling it towards this lower arch. So now the anchor is actually my lower arch, which if it goes back a tiny bit, not a bad thing, because we needed her lower arch to go back anyway. There's the superimposition tool. Okay, so there's where the teeth started and there's where they finished. So based on this simulation, actually, let me go back one step. Did I show you from the occlusal view? Okay, here, watch from the occlusal view. So when we watch this movement from the occlusal view, here's the start. So we open things up. Now watch that space. See the space opened up right there? And watch that space. It's sequential mesialization. They're moving those teeth mesially in a sequential pattern. In fact, when you do this, your eye starts to see that there was actually some asymmetry in the molar position, and they've actually made this arch a little bit more symmetrical. So I actually like what was done here. And sometimes this maybe came from the doctor doing the planning, but I don't remember seeing anything in the instructions about doing that. So we, with Progressive Aligners, one of the reasons why we chose this company is because their technicians are actually really good. And every once in a while, they'll send something back that wasn't exactly what I asked for, and I'm like, I kind of like that. When you looked at everything and figured out how to make it all fit, you decided to do this, and either like, no, I don't like that, don't do that, or I look at it and go, cool, that looks really good, but I would like that to happen, so why don't you go back and put me some button cutouts so I can put some buttons on the teeth and actually make that happen. In the lower arch, you can see the teeth are getting uprighted and aligned with IPR. So looking at that superimpose tool, the upper incisors are finishing a little bit forward of where they started, and where are the lowers finishing? Whoops. Where are the lowers finishing? That one's about right where it started, right? The one that was real far back came forward, but the other ones are finishing about where they started. So the expansion in the lower and the IPR is creating a finish where the lower incisors are staying about where they started. So I actually like this. This is showing me a little bit more upper lip support, but better overjet because I've kind of restricted the lower from going too far forward. Here's the attachments being used in this case. We could get into a lot of details about the amount of rotation, the amount of intrusion. We can click on each individual tooth in the setup and actually see values for how much each tooth is moving. It's pretty complex software if you want to get into all of it. Invisalign has all this stuff too in their ClinCheck, all of these different tools to analyze the actual tooth movement. So here we are at a progress check at 7 months of treatment. And the reason why we have these records now is because the doctor's starting to see some tracking problems. You guys see right here, you see the gap between the tooth and the edge of the aligner? That's what we're looking for. And patients come in with their aligners and we're like, what do we do here? Okay, in our courses we teach you what to do at all the appointments. But what we're checking for with aligners is we're checking to see if the teeth are moving with the aligner. So when they come in, they wear the one that they're finished with, and we put it in the mouth and we check, and if all the teeth fit perfectly, then the teeth are following the aligner well. But if we see areas like this, where there's a gap between where it wants the tooth to be and where the tooth actually is, then something's not working right there. So we have to make a decision about how do we get back on track. Can we, maybe the reason why this isn't working is because it's really tight in here. And maybe what we do is we go and do a little bit of unplanned IPR. So we're not really making big spaces, we're just lightening the contacts. We're making sure that there's no collisions happening in here. Make sure all the contacts are nice and light. Then we can I always make my patients keep their previous aligner stages. So I'm gonna go, let's go back 3 stages. And let's go back to one where it looks like this is fitting much better. And let's kind of go back to there and see if we can come back up and restart and get things back on track. Chewies are these little rubber things that the patient can bite on. Because if they bite on chewies during treatment, they're kind of forcing the teeth into this aligner. Okay, so we go back and we go, let's see if we can pick this up. Let's do some little tooth reduction in here. Let's go back a few stages, see if we can get an aligner that's closer, and then you use the chewies and let's work our way back up and see if we can get that back on track. Or we could do a revision where we just take a new scan, send it off to the aligner company, and then they send us back a new setup that we approve, and then they make a new aligners that fit the teeth the way they are today, and then get going again. But see, the minute that the tooth doesn't have good intimate contact, then you start losing tracking because it's no longer moving that tooth well because it doesn't touch it very well. So we try not to allow the teeth to get too far off track. So we got these photos because Dr. Galletley said, hey, I don't know what to do. Dr. McGann, can you help me? This is what I saw today, and I'm not really sure what to do. So we get a little progress check at 7 months. Where we're at versus where the staging said we would be at 7 months. And you can see that the lower anterior is definitely lagging along. So you go, okay, was it because she's not wearing her aligners 22 hours a day? Is it because we have collisions down here where the computer thought that those teeth would be able to move, but there's collisions happening? Are we just asking too much? Do we need to put an extra force, like a little chain or a button or something to help the teeth move? So she's only on number 12 out of 21, and we have a problem. This is what stage 12 should look like in the lower arch. This is, if we go click through that little simulation and go, what should she look like at tray 12? This is what it should look like, but that's what it actually looks like. So where's the problem coming from? That's always the number one reason, is she's not wearing them enough. So by me, because she's got number 21 in her head, I just got to get to 21, then I'll be done. And so rather than keep handing her aligners, I go, no, we're going to go back. You're on number 12. We're going to go back to number 9. And we're going to work our way back up to number 12 until it's straight. Then you can have 13 and 14 and 15. So when we do that, it sometimes encourages better compliance, because we're like, no, you don't just keep going even though your teeth aren't moving. You got to get your teeth to move. So that encourages them to wear the aligners as much as they need to. But I'm also going to go through there. In fact, in my office, we do this at every visit, is we always check with a little interproximal strip to make sure that the contacts aren't tight. Because the computer, when we do a scan, the computer's not seeing the interproximals. So when it separates the teeth and starts moving them, it's inventing the interproximal space. So even though the computer might show that there's no collision happening, clinically there may be a little collision happening. So we're always making sure that those contacts are nice and light when we do aligner treatment. Braces, it doesn't matter, because the braces will just let the teeth go where they want. But when the plastic is around the teeth, it limits what the teeth can do. So if there's collisions happening, it's not good. Also, it looks like there was a detachment for this tooth, and that one they postponed to a later date because there was no room. That tooth was so crowded in there that there was no room. So talking about brackets, this is a case where if we'd started with aligners in the upper and brackets in the lower, we wouldn't even be having this problem. And maybe the patient didn't want braces, but like, hey, you get an upper aligner and you get lower brackets until the lower crowding is pretty much gone. That'll take me about 4 months. And then we'll take the braces off and do a revision and get you aligners for upper and lower and finish up the case. So you can do this with aligners. You'll see we do get it done with the aligner, but if you look at an efficiency standpoint, braces were more efficient. Another reason why we could have a lack of tracking is it could be that the neighboring teeth that are supposed to be intruding, it could be that the teeth that are supposed to be intruding are not doing a good job of intruding, and so it's creating this gap right here. But again, that would be coming from either her not wearing the aligner or there not being enough space between the teeth. So we always keep those interproximal contacts very light. So Dr. McGann's comment to her was, make sure that the IPR that was scheduled has been done. Maybe the doctor forgot to do the IPR. Because remember there was scheduled IPR? If the IPR didn't get done, of course it wouldn't be tracking. So like, hey, make sure you did the IPR. It may be due to the fact that the adjacent tooth is not intruding, and we need an attachment on that tooth. The setup is too unlike the actual chair side, so I think a revision is needed as soon as the trays do not fit anymore. So instead of going back and trying to get the trays to fit, he said, let's refine the anatomy, because that wasn't done at the beginning, making those edges look nice. He's like, let's refine the anatomy and take a new scan and get new aligners and just start over at this point. So they submitted a new scan to start over. She said, the Dr. Gillespie says, I just thought I'd send through smooth teeth plus scan for your records. Due to the amount of tooth loss on the lower central 4-1, I've discussed with the patient building it up at the end rather than trying to remove it. So you can see now how she's gone through and done a little bit of reshaping, recontouring of the teeth. So I guess this one is going to be restored later, but the other ones all kind of got. But look at those incisal edges. See how that is a lot easier to work with for the technician than what we had originally. And all those lower incisors are refined a little bit. Okay, so new scan. This doctor chose to, I still see some attachments on there. It looks like the anterior attachments came off and the posterior ones stay on. Because it takes some effort to get those attachments bonded on there. And so sometimes for revisions, we'll take off all the attachments and kind of start over. And sometimes we'll leave them on and maybe just take off the area where it wasn't working so we can kind of rework that area. We go into all those protocols in our full courses. See, there's the attachments that stayed on the teeth, but there's none on the front teeth. They were removed. So a new setup comes back. Okay, so basically the aligner company just treats it like a new case. You don't pay again, but they just go, okay, well, this is where the teeth are today, and what do we have to do to get them back straight again? That's why they don't really care. If I do braces on part of the teeth, I don't even tell them. I just let them assume I'm using their aligners, but then I just put brackets on and we just throw away the lower aligner until we get to the point where the lowers look good. Then we transition over with a revision and go, hey, they don't care. Just whatever it looks like today, that's where we're at. And then we'll just make you new aligners to get from where we are today to where we want to be. So we get a new setup to look at to approve. So let's look at that new setup. So you can see those new attachments going on, and now there's some new IPR indicated. So here's where we're at right now, and then this is what's planned. Let's see what they're doing with the space, if they're still doing a spacing thing on that left side. Yeah, see, they're still needing to bring all those teeth forward. So if I was redoing this case today and I was the one mentoring, I would be like, hey, let's get a class 3 elastic on there just to make sure that those teeth come forward. But having said that, the staging they're doing is the best way to get those teeth to come forward without using the elastic. So think about, remember how they created a space between the canine and the bicuspid? If you took the whole section of back teeth and moved them into that space altogether, chances are that would not happen, and the front teeth would come back into that space. But because they moved one tooth at a time, you're basically using all the other teeth as an anchor, and you move one tooth, and that basically adds this anchor, then the next tooth, then the next tooth. So the staging is called sequential. They're moving one tooth at a time. So without the elastics, that's the best staging to make sure that you got what you wanted. But then the elastics would only help make sure that that happens. It gives an extra force to make sure that the teeth go the direction we wanted them to. But it actually worked out okay. If I remember correctly, we'll look at it. A little bit of IPR being done down here. And again, the IPR is not being done to get the teeth straight. The IPR is being done because we saw that there's going to be insufficient overjet unless we take away some lower tooth mass. So just because you see IPR here, it's not because we just let the technician throw IPR in to get teeth straight. The IPR is to help coordinate the arches, okay? Here's the superimposition. I don't really love that it's showing a little bit of retraction of the upper incisor here because we wanted to keep those upper teeth forward. This shows the staging. You can see that each of the different stages is active. So here we are now at 15 months. I think the last one was, what, 7 months? And now we're at 15 months. So now, a year and 3 months into treatment. And we're taking pictures because she feels like they're ready for a second refinement. How do you guys feel about the tracking from what you can see in this photo? Does it look like the teeth are tracking with these aligners? Do these aligners look like they fit the teeth tightly? Or do you see gaps? Pretty good. Where do you see gaps? Do you guys see like this one right here? Between that lateral and that? Upper laterals are hard, right? With aligners, it's hard to get your upper laterals to always follow that. So you'll see that sometimes. And then have you ever heard about the like sling elastic where you can put a little button on the buccal and the lingual and pull that down by wrapping it in an elastic? So there's little techniques you can do when you see stuff like that to get things on track. We go over all that in our courses. Okay, but generally things are looking pretty good. Like things look like they're fitting pretty well. Let's see what her teeth look like. How do you guys feel about the upper arch? Looking pretty good. Yeah. For me personally, if I'm early in the case, I like to leave the attachments on. If I'm later in the case, the attachments they wear down a little bit, and there's really not that much surface area anyway. So if it wears down from putting the aligners in and out and brushing and eating, whatever, I'd like to get fresh attachments. Plus, if we're later in the case, we may have attachments we don't even need anymore. And we may need a different size or different orientation for the movements I still want to get. So if I'm towards the end of the case and I feel like I got my invested time out of what I put in initially, then I'll remove everything, and as we get towards the end, we'll maybe just have a couple that still need to go on. But if I'm early, like she was on tray 12, that's a lot of work to take everything off and then put it all back on again. So earlier in the case, I leave them. Later in the case, I tend to take them off. So you can see that this tooth isn't looking good because it's going to need to be restored. And then here, this kind of big step, these teeth weren't tracking really well. So I don't really like that. That tooth needs to come down a little bit. Still not perfectly aligned down here. You can see why we're doing a revision, because it's still not perfectly aligned down there. So at 15 months worth of treatment, where is the aligner struggling? Right in that lower front right here. And maybe part of it's due to her compliance, but it's still a liner. But if I had brackets on her, I could have fixed that lower front in 4 months. So we teach a lot of cases like hybrid, and I'll show you one in a minute. But hybrid braces are so efficient in some things, yeah. All the doctors are a little bit different. So what we teach you definitely need your start photos, and you definitely need to document your end photos. The more that you take progress photos, the more you will learn.
What about X-ray? How often do you take X-ray?
Start and finish. When we do braces, we also take a new panoramic X-ray after 2 months in an 18 by 25 to see what our root alignment looks like, so we can reposition brackets if we have root alignment issues in 18 by 25.
After 2 months and that's it? No final?
No, we do final. So we always do start and final. But if I'm in aligner treatment, I don't take additional X-rays during treatment. But if I'm in bracket treatment, I take one after 2 months and 18 by 25, which for us is about 6 to 8 months into treatment. And at that point, if my roots are not well aligned, then I have to go reposition some brackets. So we're using that to help us with our root alignment. Yeah. Okay, so here we are at 15 months. Huge improvement, but we definitely still have a little bit of lower alignment that needs to be done, a little bit of improvement to her upper laterals. You can see the leveling that was done. See the curve of speed to start and where it's at now? So here we are now on refinement number 2. Okay, so this is the third set of aligners that she's going to have at this point. And then there's a plan to restore this tooth afterwards. But now you can see the technician has kind of moved it up a little bit to where it almost looks better to grind that off at the end rather than restore it. I'm more of a fan on lower incisors to grind stuff off, because if I restore a little corner, that won't be there 2 years later. It's just not that, unless you have a big piece of the facial or something like that you can bond. Okay, so here's the revision setup. Look, there's only, 3 aligners at this point? So there's not a lot of attention being given to that upper lateral to bring it down. It's more just to get the front teeth straight. Maybe tighten up any spaces interproximally, they're still there. So it's like golfing. You get closer to the hole, it takes fewer aligners to finally get the ball in the hole. There's the superimposition. Very small movements now at this point. So this patient finished up at 19 months.
Before and after?
Yeah, we have some before and after pictures for you. So this is the after. And I'll put them side by side, I think, in a minute for you to look at. What about her profile? Didn't get worse, for sure. I mean, yeah, she looks a little bit better. I mean, for me, that's the win. If you got straight teeth and your profile looks the same or better, great. Nice looking smile. I'm sure she's happy with her smile. Here's her teeth. You can see that there's still some composite or something that needs to be done on that one tooth to make it look ideal. Or maybe she just leaves it like that. It's probably up to them. You can always use your retainers as bleaching trays. You can use your aligners as bleaching trays. So I like to help them get their teeth whitened up towards the end of treatment. How is her gum looking? Whoops, let me go back. How is her lower anterior tissue looking? Looks pretty good. You know, we knew that she had good tissue to begin with and didn't really have too much of a worry. Still didn't get that tooth perfect, did we? Still see that rotation right there? So again, brackets, that would be gone. We wouldn't have struggled. In fact, this case wouldn't have taken this long. Because what were we, 17 months? Is that what it was? 19 months? If you did a hybrid on this one where you started in 4 months in brackets, you could probably have been done in like 10 months because you just have another like 6 months in aligners afterwards just to finish it up. Yeah, and there wasn't much to do on the top. But remember, they were trying to torque, and then they were trying to move those teeth forward. Like, didn't look like there was a lot to be done, but then the way that they staged it ended up being a lot more, but it also complemented her profile. It actually helped her get some fullness there because moving back teeth forward is a lot of work, but it actually worked out. You know, these spaces all got closed up. It looks really good. So there's the final scan. Now there's your before and after, but look at her profile. Definitely not a huge change. She looks like she aged more than less than 2 years because she just stopped doing the hair coloring or something. What's interesting though is, I always think this is so fascinating. Which of these faces looks more relaxed? Does she not look a little bit more relaxed here? And this looks a little bit more, just a little bit more irritated. I don't know what it is, but whenever you see these brachyfacial patients, their start pictures, they just look like they're in a little bit more pain. And at the end, it's almost like they've been wearing a splint full time for 2 years. And their jaw doesn't hurt as much, and they don't have as many headaches, and they just look softer in their face than they did at the start. And that definitely is what I experience most of the time with my patients who are doing aligner treatment, especially, because it just acts almost like a splint between those teeth. Marlene, I'll show you when we take our break here in 10 minutes what her final photos look like, but we're in the middle of her final photos here. We were looking at her profile change. Not a huge change, but definitely a little bit more fullness in her lips. And we were commenting on how her face looks a little bit more relaxed. So she's getting fewer headaches. Her jaw's not trapped. You know, everything's just like she wore a splint for 2 years. So there's the start. There's the finish. So question, can you fix that amount of crowding with an aligner? Yeah, you can. Would it have been easier with braces? Guarantee you. This was 19 months total. And we were saying that you see how even it's still not a full correction. Like that tooth didn't get fully corrected. And that's the reality with aligners. And whether it's the patient wasn't wearing the aligners 22 hours a day, or the way it got set up, there was little collisions in there, whatever it was, that was undercorrected. And if we'd have done braces, it would have happened a lot faster. So it's not that you can't do it with the aligner. And if that's what the patient wants, and she's like, and I go, well, do you want to start with aligner in the upper and braces in the lower? It's like, absolutely not. Then okay, we can get there, but it's going to be longer, harder. But, you know, this is one of Dr. Galetli's first cases. She did a great job with it. You guys could do a case like this right now. This is not the easiest case, but you could definitely do a case like this right now. So aligners, advantage, Patients can remove them when eating, brushing, flossing for special events like weddings and important meetings. Better for aesthetics and comfort. Aligners can do a better job of upper molar distalization. It's hard to do with braces. Aligners are better for treating dental open bites. Brackets have advantages, though, of not being dependent on patient compliance. They have better control of torque, rotation, root tipping. Better for extraction cases. Brackets are better for deep bite cases, and brackets have less of an upfront cost to the doctor. But disadvantages of the aligner, remember the same advantage of the aligner, which is patient can remove, is one of the major disadvantages of the aligner. Patient can remove. So it's a big strength, but it's also a big weakness, right? Patient success depends on patient compliance. You don't have as much control for things like torque, rotations, tipping, extractions, and then small clinical crowns and deep bite, not great with aligners. But disadvantages to brackets, they're not as aesthetic, they're not as comfortable. If you put brackets on an adult, they're like, oh, it's bugging my lip, you know? I mean, it can be challenging for them. They get over it, but it's harder. A lot harder to clean and floss their teeth. Not as good for dental open bite cases. And then there's certain things that aligners do well that braces don't do. And brackets require more of my time in the clinic. Aligners, I'm like, I do the planning, and once I've done the planning, my assistant does everything except the IPR. I do the IPR. Everything else my assistant can do. She places attachments, she removes attachments, she does all of the checks, everything. So for me, an aligner case is just bigger lab bill, but less of my time involved in it. So why would we use brackets? Well, because you guys saw how long it took to get that other case, lower teeth straight. Look at this case. How long would it take to get that straight with aligners? 15 months. I mean, you could do it, but you get there. That's not done, but that's 4 months. So you tell me which one's more efficient. Okay, I mean, there's still stuff to do. But you could literally put these braces on and say goodbye to the patient and have them come back in 4 months, and it would look like that. And all you did was put the brackets on and tie the wire in. And now they're like, I'm good, no more pain. Yeah. So, and if I was going to continue this case in brackets, then as I work up through my arch wires, I'd be able to get the roots to move underneath the crowns. Okay, there's a lot that needs to be done here still, but that initial leveling and aligning is very efficient with brackets. So if I'm looking at a case like this, and I go, hey, you know what? Give me 4 months with lower braces, and then we'll switch over to aligners and finish up the case, and you pound that out in 4 months, that's huge. That's a huge win.
Doctor?
Yeah.
Was 9 and 10 crossbite? Is it enough, right? Or is it lower? 26 and 25?
I don't know if this was in crossbite. This is just a lower arch.
Or anything is in.
So I'm assuming that if we looked at this one, that there would be no teeth in crossbite. We would just have a big overjet. Yeah, this is lower. So we use brackets because faster initial alignment, it corrects rotations faster, it's more efficient root alignment. Not in that initial flimsy wire, but when we get into the rectangular wires, it can actually get those roots to move underneath those crowns quite well. Does a better job of leveling the curve of SPE, better torque control, much better for deep bite cases, non-compliant patients. Uprighting molars, if you have a space where maybe they lost a lower first molar, and you have a second molar and a third molar that have tipped mesially into that space, and you want to restore that space, aligners really can't upright that. If you were to extract the 8, then you could probably upright the 1 molar. But to get both of those teeth to upright, you can do that with braces, but you can't do that with aligners. So there's certain situations where you just can't do some things with aligners, yeah.
If you were planning to finish it with brackets, what's your wire sequence?
So our sequence is we go from a round NiTi, like 012 or 014, into an 18 by 25 heat-activated nickel titanium wire.
Still around?
No, rectangular at that point. So 18 by 25. And that establishes some of our torque and starts to level, but it's still nickel titanium. And those are cool wires. You heat them, you cool them, and they become very flexible. And then in the mouth, they reheat and they move teeth. Then we go into a 19 by 25 rectangular stainless steel wire. And then we go into an 018 round stainless steel wire for finishing that we can put little finishing bends in. So that's our wire progression. Sometimes we use an 020 stainless steel round wire. If just certain cases, we end up needing that as well. Why don't we take a 10-minute break? So let's be back here at 3. It's like 10 to 3. And then we'll just get as far as we can until it's 5 or until you guys want to leave. Okay? I'll talk to you a little bit more about brackets. Yep.
I'm just gonna take 3 minutes of your time, doctors. I'm sure everyone looks a little better from this angle versus the back room. But I just wanted to explain a few of the details on this board right here. So first of all, I'm Morgan. I'm probably the guy that's bugged you multiple times on the phone or via email. So I know I've bugged you a lot, but it's good to see everyone here. Dates for all the North American classes, at least here in the States, are going to be listed right here. I know you got a question about the hybrid, so that's going to be a same course, the same curriculum, just a different model of learning. So we'll have the 10 course here in Orange County, but in Sacramento, which is our closest hybrid, is going to be the 10 seminars packed into 4 in-person modules. Same curriculum, just a different way of learning, so all the hands-on portions are going to be put into those 4 3-day weekends. And then in between those modules are going to be the lectures that you'll watch via recordings. Make sense? Okay. There's obviously Austin, New York, Chicago, Toronto, which just started, and Atlanta. They will be separated out based off what learning model there is, so hybrid versus the 10 seminar.
I think our closest, San Jose is our closest modular one.
So it would actually be Sacramento this year.
Sacramento.
Sacramento, yeah. We do have a refer a friend program, right? So if you end up enrolling and you want to enroll with somebody else, we do have 2 benefits. One would be a $300 reward that you can either apply to your education or you can apply it to supplies, right? Whether that be aligners, brackets, wires, bands, anything of that nature. You can split it. So if anyone's interested here today, you guys can actually split that $300, $150 each towards your tuition, or you can choose one free Progressive Unlimited Aligner package, which is valued at $1,700, right? Everyone who enrolls automatically gets one of those instantly, right? So you get one free automatic Aligner Unlimited case. In addition to that, you get the free retake lifetime policy. You get access to SmileStream, which is our video hosting platform. It's going to contain all the recordings from the previous generations of education. And then after the OC class goes through each seminar, we're going to be uploading the new recordings from those classes. We do this every 3 to 4 years. New curriculum comes out. Obviously, Dr. Colantero rewrites that. We re-record it. We upload it to your account for free. There's no additional charge for that. It's part of our program that we have for eternity. Okay? Any questions on that? Thank you. One additional piece. We do have obviously discounts. If you pay in full, you do get a 20% discount, which is the highlight we're running for 1 day free intros only. There's other discounts. If you pay per seminar, there is no discount. It's $1,800 each seminar. But obviously, if you pay in full, there's benefits to that, like the 20%. Right? We could break that up into 4 monthly payments, which brings it from $18,000 down to $14,400. If you break that up into 4 payments, it's $3,600 each. Pretty straightforward. Cool.
Do you guys have any questions for him regarding?
I talk fast, so.
Sorry if I missed it. I think you also mentioned over the phone the seminars are Thursday through Sunday.
Indeed. So each one will be, that's for the 10 seminars.
For the live ones, which is my favorite way to learn. I like coming here and learning with a group and whatever, but yeah.
Yeah, and actually something good about that as well, right? So if you think about if you're going to learn this class specifically, it starts in May, right? So the next seminar would probably be, I believe, in June, right? So you'll be taking patients after that seminar. You'll be qualified to start taking patients right away, right? Versus if you were to wait for the hybrid model in November in Sacramento, you'd have to actually wait till 2026 to be certified to start taking patients, right? Because the second module is not till probably February or March of the new year. Okay? We do encourage you to start taking patients right away because it solidifies the education that you're learning. What we see a lot of is doctors who get through, let's say, seminar 7, and then they finally start taking patients and they have to go back and re-watch all the old curriculum, right? So it's better to start implementing it, build muscle memory, start applying what you're learning early on. That way you get courageous, right? You actually start building muscle memory, it makes it easier for you, and then obviously you have the benefit of having mentors and consultants at your fingertips. I believe there's 48 listed right now. So whenever you need support, you not only have me, tech support, all of our supply team, Dr. Harold, there's 47 other doctors available to you, and pretty much hold your hand the whole way through.
Thanks, Morgan.
You got it.
And in fact, those of you guys that are here, if you're thinking about taking this full course, I would say start finding patients right now that would be potential patients. And you can email me some pictures for free, and I'll just look at them real quick and go, that'd be a great case for you to do when you start the class, because what you want to be doing is identifying people right now, whether it's family members or staff or maybe a patient that's interested. If you can get a bank of 5 or 10 patients that are interested and send it to me, and I'll be like, yeah, that looks like a good case, hang on to that. Then when we get to seminar 1 and 2, you're like ready to start doing these things right when you get back to the practice. So.
With your permission, can I leave?
Absolutely. Thank you for being here. I appreciate your comments and questions. Yeah. Hopefully we'll see you again.
Thank you.
All right, so let's look a little bit at brackets. Here at Progressive Orthodontics, we have our own bracket system. And the reason why we have our own bracket system is because Don McGann, as he was using brackets, he's like, the orthodontists have all this specialized training to bend wires. It's a hard skill to learn. General dentists, it's not a skill that we have. So he wanted to invent a system of brackets that would help to alleviate all of the wire bending that orthodontists do. So we end up with a large variety of different features, we'll call them prescriptions, that are included into the brackets. It would be very difficult to inventory all that. So the way it works in an orthodontic practice is a patient comes in, and the orthodontist's goal is to put braces on them that day. Okay, so in their inventory, they have a couple of different prescriptions, is what it's called in the industry, a couple of different bracket prescriptions that they'll go and pull one out and put it on the patient, but then they know how to bend wires throughout the treatment to be able to get the things out of the teeth that they didn't get out of a bracket prescription. Okay, because each bracket has got different cuts, different angulations. There's actually, each bracket is specific to a tooth to get the tooth to move where that tooth should be to be straight. So it's a prescription that's in each bracket. So we have a much more complex system of prescriptions. And then rather than have a gigantic inventory, because the orthodontist wants the patient to walk out with braces that day. Because if they walk out without braces, they might go somewhere else. They might never come back. But in my practice, my patients are already my patients. There's no, they might go somewhere else. And there's no urgency. I don't have to, if somebody says, yeah, I might be to straighten my teeth, I'm like, let's put braces on today. So I go, oh, cool. Well, you know what? Either today we'll take some pictures, or you can come back another day, we'll take some pictures, then I'll look at it and decide how the best way to treat it is, then we'll talk about it, then we'll get started, whenever we get started. That gives me time to do a custom order for my patient. So each one of my patients that I treat with brackets, I've ordered a custom appliance. We call it the IP appliance, meaning individual patient. So out of a giant inventory that we have here, I've ordered one appliance for this patient where every single bracket is the right bracket for that patient to make me have to do the least amount of work. So there's more work being done by the bracket because we have a huge inventory of different things that brackets can do, and less work for me. That's why we have individual patient. So it doesn't work well for an orthodontist because they don't want to carry this gigantic inventory and take the time to diagnose every tooth. They just pick a set of brackets that's the best fit for that patient, and then they make it work. We individually diagnose the patient and give them a bracket that once I put it on, everything should go really well. So that's the difference. Okay, so each bracket is pre-programmed for the torque, for the angulation, and for the rotation. So if a tooth is slightly rotated, I'll get a bracket that has a rotation correction so that it overcorrects that rotation. But I have to individually diagnose each tooth to get that. I want to prescribe the torque, like you heard me talking about earlier, that's going to best fit that patient's needs. And we have a whole bunch of them. And then the angulation that's going to best fit that patient needs. And I want to choose an arch wire that's going to support the shape of their jaw. So it makes for a large inventory, but that's why we order individual patient appliance. And so you can see right here, wires will interact with these brackets in different ways. So in this view, a wire can interact with the tooth for angulation. And in this view, the bracket and the wire can interact for torque, for inclination. Initially, when you put that little round wire in, it doesn't do any torque. It just spins inside there. But once you go into the bigger rectangular wires, now depending on what your bracket is, you have the ability to make the roots go to the labial or go to the lingual. So you have control over the torque with the bracket. But we choose different brackets depending on what we want. How do we know what we want? That's what the whole program is. We have a system for learning what we need for each patient. And as you heard, he asked, what was our wire progression? So this is what we have, this 5 stages of treatment with brackets. Okay, so here's a start right here, where we have in this round nickel titanium wire that I talked about that you can tie in a knot and then it'll spring back to its original shape. And the purpose of this one is to get all the crowns aligned and get all the rotations fixed. And that could take anywhere from 2 to 8 months, depending on how crooked they are and how good we are at being efficient. But usually it's somewhere around 3 to 4 months, up to 6. And then after we get done in this, then we move into what we call leveling. And we spend 6 months in this stage in this rectangular wire that's heat activated, which means that you can cool it down and it becomes flexible. And then when it warms back up, it goes back to its original shape. It's a pretty cool wire. And that one will finish leveling the teeth, and it starts to give torque to the teeth. It starts to get the roots underneath the crowns. But also, that little bracket, it's smaller, so it doesn't completely fill that. So it's almost like a combination. There's a lot of slop in there, so it's easy to put in. But it also starts to engage those bracket sides so that it starts to torque the teeth. Then, once the teeth are pretty straight, then we move into this really stiff stainless steel wire. This one, if you bend it, the bend will stay. So it's a wire that's stiff, and it resists a lot of unwanted movement. And when we put this one in, it's really hard to get in. The brackets have to be perfectly straight to get this big wire in, but that's what these stages were for. So then we put this big one in, and then this big one will finish getting all the torque expressed. Because remember, each bracket has a prescription. And so when we more completely fill the bracket with a piece of metal, it finishes expressing all of the prescription in that bracket to get the teeth aligned properly. And we can do things like close extraction spaces and wear elastics to get the bite corrected, and we do that on that stage. So this stage could take almost no time, maybe just a month or 2 to get the bracket prescription expressed, or it could take a year because we have extraction spaces that we need to close up. And then when we finally get to the place where all the spaces are closed, the arches are coordinated, then we go into finishing. And these days, a lot of our doctors are switching over to aligners because it's the case is almost done, but it's just not perfect. And rather than then start bending wires and trying to get all the little movements or repositioning brackets, they just take them off and just get a couple of aligners and just finish up the case in a few aligners. Or we can go to this round stainless steel wire or back into this wire and do our finishing and get everything just perfect. That takes a little bit more skill. So that's why a lot of people like to switch over to aligners at that point. And then we do retention. So those are our stages of braces. So this is just to help you visualize a little bit more this idea of torque. When you take this rectangular wire and you stick it in, can you see in this picture that the way the wire is not the same orientation as the bracket? So if you stick that wire into that tooth, it's going to have an impact on that tooth. It's going to give a twisting force to that tooth. It's engaging the edges of that bracket. That's how we apply torque through braces. But if we want to apply torque through an aligner, it's just plastic. So imagine that you want that root to move this way, and all you have is plastic. And so you can, have the plastic try to do it, but it's my kids, my little boys like to have plastic wrenches and stuff, and I'm like, if I'm going to go actually do some work, I'm getting metal tools. I'm not using plastic tools, because plastic just bends. This is a metal tool. So if I want to move that root to the lingual or to the labial, I am much better doing that with a metal tool than doing it with a plastic tool. Okay, so we do things with aligners, like these are little things called ridges, power ridges. You probably see that with Invisalign. It puts a little bit of extra pressure to try to get the root to move, but it's still just plastic. It still just flexes. So we have better, that's why when we say, hey, braces are better for certain things, there are things that braces can do better than plastic can do. And when we combine the strengths of both of them, we get really efficient. So hybrid treatments, we've talked a little bit about this already. When do we consider it? Well, when we have teeth that are real rotated, we have a lot of root angulation problems, like there's a canine that's all tipped over and that needs to get uprighted. That's hard to do with an aligner. Sometimes we see lower bicuspids. If you can see in the cases where like one of the lower bicuspids is kind of blocked out and tipped to the lingual side. It's hard for an aligner to get that tooth back into an alignment. It's hard to even get the aligner over it. Okay, uprighting molars, dental deep bites, and they're just faster, and you don't need compliance. Sometimes we get to an end of a aligner case and the patient's just not wearing them, and we finish a case in braces because the patient's not wearing their aligners anymore. So usually with hybrid cases, we start with braces and switch to aligners, but sometimes we start with aligners and switch to braces because it's just not working. So let's look at a hybrid case done by Dr. Kelly Huang in San Diego, also working with Dr. McGann, and again, recent grad of the program. She graduated in 2022 here at this location and has done 32 cases with Dr. McGann as of 2023 and is having great results. So this guy walks in, he's 37 years old. This guy could walk into your practice tomorrow. Well, Monday. So let's start with his face. What do you guys see? What does his lips need to go forward or come back or stay where they are? You'd like to see him go forward a little bit? Yeah, he looks pretty concave, doesn't he? His lips are quite far behind his nose and his chin. I definitely wouldn't want him to come back, but if they could stay where they are or go forward would be better. His upper midline. This photo is hard because you see how his head's turned a little bit? When you guys learn how to take ortho records, we talk about how important it is that you're standing right in front of the patient and they're not turned their head, because when their head's turned, it's hard to see what the midline's doing. So if I can see more ear on one side than the other side, then it's hard to evaluate the midline. He has a little bit of gum tissue showing up there, so you know, if he has a deep bite, I wouldn't mind intruding his upper incisors a little bit, but I'm not really sure which way his midline needs to go. Maybe it's fine. Can you see why he wants to do braces or aligners? He's lived with this his whole life. Doesn't like it. Has money now, wants to fix it. What do you guys see? What are the things that need to be fixed here? The crossbite? What's his posterior occlusion like? You can see here with these, that looks like an orthodontic class 1, maybe even a little bit class 3. Because remember, we want to see the distal side of the upper molar touching the mesial side of this one, and that buccal groove, or that mesiobuccal cusp just a little bit behind that buccal groove. His lower teeth are a little bit too far forward compared to his uppers. Similar to the case we saw earlier. So he's a little bit class 3, but it may just be that once we work out the case that he doesn't need to move his back teeth, maybe we do a little bit of lower IPR again, like we talked about in the other case. But we wanted to see more lip support, so is what we're seeing in the mouth going to support what his face needs? Because crowding gives us what? Tooth advancement. If we have crowding, we can advance teeth. Sometimes that's good, like for him, but sometimes it's bad. Sometimes somebody already looks full enough, their lips are already out far enough, and they have crowding, and we're like, no, that's not good, because crowding is going to advance the teeth. Now we have to think about extractions or really being aggressive with IPR or expansion. So for him, seeing some crowding is actually a good thing. We want to be able to advance his teeth, so how does his lower gum tissue look? Can't see it. So one of the things when we teach you guys how to take records, one of the things we talk about is making sure that when you retract, that you retract in a way that you can see that lower gum tissue. Because here we are trying to make a treatment decision, and we can't see a vital part of information. It's covered up. I have no idea what his gum tissue looks like. I mean, it seems like it's healthy from what I can see, but I can't actually see it. I don't know. I think I can see enough to say that he doesn't have any recession because I can see the gingival margins, but I don't know how thin that tissue looks down there. So I guess I'm going to assume that it looks okay. Bites of maybe a little bit deep, not too bad. It's a little, it's not 20%. Looking there, it's maybe more like 40%. Anything else interesting? His upper midline almost looks a little bit like tipped to his right side. But when that tooth comes out, that's going to push that back the other way a little bit, so that will help. So here's what it looks like from the occlusal view. That blocked out tooth. Those are pretty blocked out. So without spending too much time on this one, his lips need to go forward. His face type, he looked pretty average to me. He didn't really look, let's look at his face type again. Well, average to, if anything, he's maybe got a little bit strong muscles, but he doesn't look like he's super compressed in that lower arch. But definitely on the stronger muscle side than on the weaker muscle side. His midline, it's hard, I couldn't tell from the photos. Upper tooth, I would say keep it about where it is in the vertical dimension. His incisor inclination, do his incisors look pushed back to you guys, or do they look flared? They look a little pushed back, don't they? Well, those look a little flat through there. So good, because we have crowding and we need lip support. So whenever you see the things in the mouth matching up with what you wanted when you looked at his face, that's always a good sign. Because you're like, oh, just straightening the teeth is going to give me what I want. But if what you saw looking at the face and then you look in the mouth and they don't line up, then this is going to be a harder case. So we like the fact that his incisors are a little bit retroclined because we can then advance them. His tissues we couldn't really see. There's his panoramic x-ray. One of the things that we didn't look at in that other case, but sinuses make a difference. We look at sinuses in panoramic x-rays because sometimes you'll have a sinus floor that's way up here, and sometimes you'll have a sinus floor that's way down here. How does that play into ortho? That sinus floor, what do you think the floor of the sinus is made out of? Is it cortical bone or is it, blanking on the name of the other bone? Yeah, the cancellous bone, right? So that's cortical plate. That's why it looks white. There's actually like dense cortical bone on the floor of the sinus. So remember the last case where we saw them moving all the teeth forward? If that patient, if we went back and looked at the pano and that patient had had a sinus like this, he'd have been like, that's probably not going to happen. Because if we could open up their sinus and look in it, you would see the roots coming up and you would see bone laced in between all those roots. And you're like, oh, there's no way I'm going to move the teeth through that. And that's another reason why sometimes we look at extracting teeth. You're like, well, if I extract a tooth and I want to close the space, if the sinus is really low, that's going to be really hard to, you're just going to get crowns tipping. And the same thing when later we'll talk in our seminars about distalizing, like maybe we want to distalize of the upper teeth. And if you're wanting to distalize but there's a low sinus, so there's a lot that we look at, that we train your eyes to look at in our courses to help you decide what's the best way to treat that patient. Now, when you look at that, what is that lateral ceph? Remember we talked about the 3 different types of patients? Does he look like his bones are really compressed and like he's really parallel, or does he look more like this? Like I do see a little bit of muscle there because you can kind of see that little like corner where he pulls on it. But remember I said to me he looked more like average? Okay, he's not like severe open like this, but he's also definitely not like that one that we saw where it was more parallel. So he's more average in his jaw compared to the last patient that we looked at that was a little bit more closed, even though he's concave in his profile. And then his incisors do look a little bit shoved back. They're a little bit flat. So here's the case that was worked up originally in SmileStream, the ceph combined with the model tracing. and the two-dimensional VTO. So what is that showing in the two-dimensional VTO? Are the incisors going forward or back? The blue is the starting position. So that was telling us that when this got combined with this, the amount of crowding in both the arches is advancing both upper and lower incisor quite a bit, which is good for his profile, and good because his teeth are kind of tipped back. So that's actually acceptable for him. Maybe we'll want to do a little bit of expansion just so we don't advance too far. But in this case, we're not going to extract teeth and we're not going to do a bunch of IPR and expansion because we want to allow his lips to go out and give him more support. This right here is the VTO that includes some expansion. This is an expanded arch form with some IPR, and then that's what it looks like. So he could definitely tolerate some expansion. What about extraction? This would be an extraction for him, because you could look at that and go, that's a lot of crowding, we should pull some teeth out. Well, this one actually then shows his teeth coming back. And we decided at the beginning we definitely don't want his teeth to come back because his lips are already flat. So that one's out. So Dr. Huang said, I know for Kevin's teeth, he has small teeth with severe crowding. It's hard for him to wear aligners. I asked him to use brackets first, then move to aligners. He initially wanted to have aligners only, but I explained why brackets first, then aligners would be better, and he accepted my treatment plan. So he didn't want brackets, he wanted aligners, but she's like, hey, you know, your case is gonna be hard. You have a lot of crowding, and I think I could do a great job with aligners, but if you let me start with brackets, it'll be a lot better. And he's like, okay, it's only gonna have to be on how long? Well, 4 or 5, 6 months, somewhere around there. Okay, as long as it's not 2 years in braces, I'll do that. So she's excited to see this happen, what's gonna go on with this case. So what did they do? They started by putting brackets from upper second bicuspid to upper second bicuspid, 5 to 5. And then, upper and lower. And then they started alignment on that 012 night-tie wire, so that little flexible round night-tie wire for 3 months. If the patient is biting the lower teeth on the bracket, then bond composite to the occlusal lower molars or lingual bite ramps. We go into a lot of detail on this in our courses, but basically, we can put little composite bite ramps on the back of the upper incisors and make it so same thing like with the aligner bite ramps where it gives you a stop, it gives them a vertical stop so that they're not biting on their brackets, and teeth can get straight pretty fast when we don't let them bite on everything. So we'll put little composite bite ramps in there to be really efficient initially. So that was the plan. And then after 3 months, they were gonna change to a little bit bigger night-tie wire to just finish the alignment, and then send pictures and check it before they take off the brackets. So here's what it looked like at 1 month. And you can see that there's brackets, upper and lower 5 to 5. These days, now that I'm using the software that shows me all the tooth movements, I'm tending to tell people to go put brackets all the way back to the 7s. Because this seems a lot easier. Oh, just put the brackets on the front. And it is a little bit easier. It takes a little bit more time to put the brackets on those molars. But when you look at how much needs to move, when you look at the simulation, you're like, oh, you know what? We should probably go ahead and go all, because usually the 7s, the upper 7 has like this distal crown tip, and the lower 7 is like curvus spee, it's up too high. And you're like, you know what? Just getting those 7s involved, because if we only do the brackets from 5 to 5, then when we take the brackets off and move over to a liner, these teeth have got all that cellular activity going, but these 7s back here aren't moving at all yet. And this is the weakest part of the aligner, because the aligner isn't very strong back there. That back end of the aligner really doesn't, there's nothing to anchor onto, so it doesn't have a lot of ability to fix anything back there. And you maybe notice that like back 7s, it's like you probably don't even move them most of the time. You may even specifically tell them not to move them, because if they try to move them, it doesn't track anyway. So if we want to really do a good job, I'm telling people now, 7 to 7. If we're going to put brackets on anyway, let's just put the molar ones on too, and let's get those moving and get really some good work done. But this was 5 to 5. This right here is stainless steel open coil that's been packed on the wire in the spaces where these teeth are too blocked out. And what that's doing, that's just blowing open space so that this tooth can come out. So when we talk about being efficient, you know, your first bracket case, you might not be that efficient, but as you learn to do this, you learn the tricks, and we teach you the tricks to be able to get in there and be efficient. So this one is nice and packed. This one needed to be reactivated, so they put this little, you know, they pulled the wire back and put a little thing on there to give it more activation. Look at the difference here. Do you guys see the wire deflection right here? See how this wire is being bent in towards that tooth and bent back out? There's a force pulling that tooth out. This was too far away from that, so they're just opening up space to be able to get the wire all the way in there. These are pictures at 2 months. So at this point, there's been enough space created here that they're at least going to kind of tie the wire to it. So now you not only have space being opened, but we've also attached the wire so it's pulling that tooth out. Down here, remember the one tooth that had, this was the one that had the coil between it. This one just had the deflection. So the deflections come all the way out. Look at, let's go back one. This tooth right here that just had the wire deflection, 1 month, looked like that. Okay, that's just what the wire wanted to go straight. And then this one, which they had the coil in there, see the coil? Now, now there's a big enough space to do the wire deflection, so in another month or two, that one should be straight. So we're at 2 months right here. And here he is at 4 months with the braces off. He's feeling pretty excited because that's a big change for him in 4 months' time. And now he gets to switch to aligners. That was worth it for him to spend 4 months in brackets. So this is what his teeth are looking like. Remember this one? So it's not perfectly straight yet, but that's a huge change from where it started. This one was the one that was blocked out. Now, if we were doing braces, we would now put in that 18 by 25 rectangular wire and start to get these roots to move underneath those crowns, because all that round wire did was just pull all the crowns out there. But that's a huge amount of work to get done in 4 months compared to what aligners would be able to do in 4 months. But, you know, the case isn't done. There's still plenty to be done here. Look at how much still needs to be done right here in this area. And then getting all the teeth straight and coordinated. But man, that's a lot of progress in 4 months. There's the panoramic at 4 months. What's interesting to see in this panoramic x-ray, can you guys see the wide PDL space right there? That's what happens when we do ortho. That nice tight PDL gets widened because that tooth is now moving around and the body's remodeling that whole thing. So when we see wide PDLs, it tells us that tooth is orthodontically active, and when we move to the aligners, those teeth will keep moving well because that PDL is already expanded. But the PDL on those 7s is still completely tight because we didn't move those teeth at all. Look at the difference between the Ceph. Can you guys see the difference in the angulation of the front teeth? Do you remember that very first VTO that we showed where you could see how the front teeth were going to come forward? Isn't that exactly what happened? When we straightened all that crowding, his teeth went from being back like this to being forward like that. And in some patients, that might be awful. If their teeth were already too far out and they already were too full, and you do that, and you're like, no, this is terrible. We need to pull teeth out. But in his case, that just makes him look better and puts his teeth at a better angulation compared to the start. So this is called a Ceph overlay, where you can actually see what changed, where you take the first Ceph and the second Ceph and overlay them and trace it. You can see from a skeletal standpoint, nothing changed. The bones are all still the same. His lips have, when you trace it, maybe you can show that his lips have come forward because you can actually trace the lips. The molars haven't moved at all from the start position because we didn't even have them in the brackets. But look at the blue versus the red from that 4 months of treatment. That was a pretty big change to those front teeth, huh? And maybe we don't want to leave him out quite that far. Maybe now at this point, we might want to, with the aligner, we might do a little bit of expansion, a little bit of IPR. You know, we can reevaluate the case when we switch over to aligners. So see, that was the very first VTO that showed what the teeth were going to do. And when you look at the tips of the incisors, you can see that, yeah, they did go forward probably that much. So at this point, we didn't have an intraoral scan at the start, but we got an intraoral scan when they took off the brackets and decided to switch over to aligners. I think I can show it to you. See, what case number is this? $15.89. I'll show you it really quick. So this is what his scan looked like when they took the brackets off. Okay, so you can see there's that tooth that was blocked out. This one was blocked out. You know, it's not done by any means. There's still work to be done. Looking at the arches individually. Oops. I mean, that's not done, right? If we would have spent more time in brackets, it would have actually been better, because look at this leveling right here. Like, I would have liked to get these incisors more leveled. That one's going to be a little bit of a challenge right there. But that was the one that was completely blocked out, and it's only finally just gotten aligned into the arch. So if the patient was willing to spend more time in brackets, we could have even gone further with it. So the longer the patient's willing to spend in brackets, the closer we can get to the hole before we start using aligners to start golfing with, right? In the upper, remember this was the tooth that was completely blocked out, and you can see that that root still needs to move labially. But a lot was done. Do we still have a rotation to correct on that central incisor right here? And then just a lot of arch coordination. Because look at that overjet right there compared to that overjet right there. So the workup in the app, I'll just open the one that was done. Let me look at simulation 1.1, which is just the straighten the teeth only one. Okay, so here's what it's predicting will happen if we just straighten the teeth from where we're at. So let me show you the little simulation. So here's what his lower arch looks like right now. And if we just finish straightening, it's predicting that amount of change. And in the upper arch, we're here, and it's predicting something like that. When you look at it, we have that overjet problem again. Remember we said he's a little bit class 3? So that class 3 is causing this overjet problem right here. So just like with that previous case, we can look at non-extraction with class 3 elastics. We can look at non-extraction with expansion in class 3 elastics. We can look at non-extraction with IPR in class 3 elastics. So my question is, what is this looking like currently on his face? We already saw, remember, we don't have his start one, but you guys saw that start one earlier, and he'd already had a lot of advancement. So maybe at this point, we don't really want any more advancement. Like, that was enough what he got already. So it may be that just finishing the alignment isn't going to be the best option. So maybe we want to do a little bit of IPR in the lower arch, something like that, so that we can limit the lower incisor advancement. And it wouldn't be bad to get more upper, because that would just give him more upper lip support. So he's probably going to need some, just like that last case, he's probably going to need some lower IPR and maybe even some class 3 elastics. But probably at this point could get away with just doing lower IPR. So let's see what was done on the case. So this was sent to progressive aligners with the instructions not to put an attachment on the upper right 6, the upper right molar, first molar, because there's a crown and they didn't want to bond composite to the crown. They asked them to increase the amount of activation because the teeth were already moving, but to put on attachments and IPR is needed. Upper midline is centered, so try to center the lower midline to the upper. Again, I'm not that concerned about the lower midline, so I don't usually write that. Correct rotations without collisions and continue until 4 degrees overcorrection of these specific teeth. These were the ones that started out rotated, so we're going to overcorrect to compensate for aligner weakness. We want to finish with ideal overbite and overjet, 2 millimeters of overjet and 20% overbite. So let's look at the setup that came back. Here is the screenshot of the setup. Here's the actual setup. So here's what came back from progressive aligners. There's the attachments, and look at the IPR. Just pause it right there. .2 millimeters in the upper. Again, I probably wouldn't have wanted any IPR in the upper, but it may be, we'll see at the end, it may be that when they aligned those upper teeth that it tended to like create a little bit of a black triangle between those teeth. You guys know what I'm talking about, the black triangle up at the gum line? And that they wanted that .2 millimeters to get rid of that? I'm not sure. But if we just specified no IPR in the upper, 0.2 is not bad, but I can, whoops. I always want to play with this model like I'm actually in the software, but it's just a recording, I can't do it. So there may have been a little black triangle right there. But generally, if I don't usually put IPR in a case to get rid of black triangles just because they show up in the software. I want to see it actually happen clinically before I would want to do IPR just for that reason. So in this case, I'd probably prefer no upper IPR and only lower IPR. But look at how much lower IPR we needed in this case. Whoops. So look at that. 0.4, 0.5, 0.2, 0.3, 0.2, 0.3, 0.4. So there's a decent amount of IPR in that lower arch, as we could tell from that simulation that we ran earlier. So it's nice to know before you submit it, you're like, just look at the simulation and go, oh, I can tell I'm going to need either lower IPR or I'm going to need class 3 elastics or both. And then you decide what you want to tell the technician. Okay, so the teeth get straight, everything gets brought together. And then at the very end, do you use, Dr. Park, do you use virtual chain to close up spaces at the end of your cases? So progressive aligner calls it residual space closure. At the end of the case, it's a couple of overcorrective aligners to just move all the teeth closer together, and we don't give them all to the patient, but if they have any light contacts that aren't very tight or any little spaces, then we give them the first one and then recheck and then give them the second one, and that helps to tighten up any contacts that are kind of loose or where there might be little spaces left over. So here, you see on the bottom, these 3 stages right here that are black, right there, those aren't actual part of the treatment. The treatment stops here, and these 3 are called residual space closure aligners. So you'll see when I'm showing it that I'll kind of show you those last 3 and how it just tightens everything up. You'll see it better when we look at it from the occlusal view. Okay, so here's what's happening from the occlusal view. A little bit of expansion. You can see that kind of rounding out that arch form. And then see at the very end, see how it pulls everything closer together? Those are just overcorrective. That's not really exactly what's going to happen clinically. We just have those in our pocket in case we need to tighten up spaces. So a little bit of expansion in the upper and just overall alignment. In the lower, you can see the different stages for the IPR because they only apply it when the contacts are straight. And then there's the little overcorrective at the very end. See the overcorrective right there at the end? Okay. In the posterior occlusion, Everything from that view looks really good to me, except I'm not very optimistic about what I see happening on that upper 7. Chances are that's not going to happen very well with an aligner. But if I wanted that, then I should have done that with brackets when I started the case. I should have gone all the way back to the 7s. See how these 7s, this is real typical. Lots of people have this, where that upper 7 is kind of tipped up like that. And if we really want to align everything, then we should start our brackets back there. Okay? So the setup followed the instructions and was approved. There's the superimposition. Remember, we're seeing a little bit, the incisors are coming back a little bit from their start position. But remember how the start position was back, and then we did the braces and it went way out? We could see that in the Ceph. And now we're doing, with our aligners, we're bringing it back just a little bit, just to get everything look nice and with a little bit of expansion there. Here's the IPR that's indicated. This is the Bolton discrepancy I was telling you about. See here, we can measure. It'll give us a Bolton analysis, and it's telling us that the upper arch is bigger than the lower arch. Maybe it's because those bicuspids are kind of big bicuspids, or maybe it's because the canines are kind of wide canines, or maybe because those lower central incisors or the lower canines are a little bit small. But whatever it is, the upper arch has got more tooth mass, quite a lot, by 2.46 millimeters than the lower. In a class 3 case, that's really good. We need more upper tooth mass than lower because we need to get those uppers out in front of the lowers. But sometimes that indicates, that we might need to do some IPR in the upper arch to get the arches to coordinate. But in this case, rather than fix his posterior occlusion, we're just allowing that tooth size discrepancy to give us ideal overjet. So he has 24 aligners plus those residual space, or 21 plus the space closure aligners at the end. So 24 trays were accepted. Can you guys see the difference between here? This is the actual treatment from start to finish, and this is after the overcorrective aligners. We're not actually going to do that. That's just in case there's spaces that didn't close. Like maybe when you did your IPR, you did too much IPR. So that's what the overcorrective aligners are for. And then Dr. McGann, who set up this case, likes to get into all the details of how many degrees of rotation. But basically, we correct like 1 degree per aligner. So when you see 19 degrees of rotation that's needed to correct a tooth, we correct like 1 degree per aligner. That's why we're up around 20 aligners, is because we have a 20-degree rotation of a tooth to fix. If we try to go faster than 1 degree per aligner, then the tooth just doesn't track with the aligner. We're able to evaluate with a little contact tool to see what the contacts look like. And I don't know if you do this, Dr. Park, but on our cases, we tend to, unless it started with open bite in the front, we like to finish with real heavy contacts on the back teeth and no contacts on the front teeth. Because the tendency for aligners is to finish with contact in the front and open bite in the back. So we try to counter that by finishing with kind of an open bite in the front and nice heavy contacts in the back. In the treatment plan. So what you're going to get clinically is going to be different than what the treatment plan shows. Yeah, do you see here how we're showing it with contacts in the back and nothing in the front? Here's the thing that's for people that are new to doing aligners, one of the things that's challenging is that you think that these setups that you're getting back represent the final position of your teeth. And they don't really. They actually represent the shape of the aligner. And the shape of the aligner just represents the forces that are going to be put on the teeth. So if we overcorrect a rotation, it doesn't mean that the tooth's going to finish like that. It means that my aligner is going to have a shape that's going to put extra force on that tooth to try to get the tooth straight. And if we have a deep bite, I want my setup to finish with an open bite in the front and heavy contacts in the back. It's not going to happen clinically because the aligners have insufficiency. They're plastic. And so we have to get over the fact that we get super hung up initially on trying to make the setup look exactly right. And you're like, the setup is not really a representation of the final tooth positions. It's a representation of what forces are going to be applied to the teeth. And on our first set of aligners, when we're taking that first swing to try to get to the hole, we might have a lot of overcorrections. So like if I have a patient with open bite in the front, my first set of aligners that I order will have almost like a deep bite in the front and completely open bite in the back. I'll finish with molars like way apart from each other. And I'm not gonna get that in the clinic, but that's the forces I want applied to my teeth. And so sometimes I'll even do one setup that looks more ideal to show my patient, but then the ones I'm gonna order are the ones that have these overcorrections on them. But then as I get closer towards the end and everything's looking just the way I want, now I'm really detailing it. Those final ones kind of do represent the final position of the teeth. But early on, I just am trying to throw forces at the teeth to get them to move where I want. So we have to be okay with these overcorrections. Like if I want torque, sometimes I'll put more torque, so the tooth will look a little funny in the setup. It looks ugly in the setup, but like that's what I want on the teeth, is those forces. It's a great question. So now here he is at 15 months total treatment. So he was 4 months in braces. There was probably a month of transition there where they were taking off the braces, getting the aligners set up, getting the aligners ordered. So at this point, he's probably like 10 months into aligner treatment, which makes sense because there were 20 aligners and they were probably changing them every 2 weeks. How often do you change yours? Weekly? And then after that, you do 10-day or you go 2 week after that? So here he is at 15 months of treatment. Looking pretty good. You can see the attachments are still on there, but teeth alignment is looking pretty good. In fact, you're gonna see that there's a lot of like revisions here and stuff, but nothing actually gets much better than it is right here. And I see that a lot with aligners, where it's like 90% of the stuff got done in the first like 6, 7 months, 10 months. And then after that, we'll spend another 10 months dinking around. But really, like, the patient starts getting tired of wearing them. Their chief complaint, like the excitement of wearing these and getting their teeth straight is kind of gone because now we're just doing little details. And sometimes the fact they stop wearing the aligner as well, instead of seeing teeth get better as they wear their revision, you'll actually see them start getting worse because they just are over it. They don't wear them as much. So we do get patients burnt out sometimes. And initially on that first set of aligners, they're real diligent about wearing them. They're excited because their face is changing. And then when they're pretty happy. And now we're trying to detail it out and get it all perfect, and they're kind of over it. They're not wearing it as much as they used to. But at this point, 15 months, the patient was scanned and attachments were all removed so that they could get revision. So this was a good chance to kind of just compare start to 15 months because all the attachments are off. That looks pretty nice, huh? Remember how that started? Those teeth were like all completely out of whack. Look at that tooth's gonna probably need, it probably was a non-vital tooth and it's probably needs some internal whitening. Here's what the scan looks like at 15 months. So what are the refinements being done? I can kind of see this tooth, that upper right lateral, it's not perfectly aligned. There's definitely some improvements that could be made there. Lower teeth look pretty good. I mean, maybe that lower right lateral is still a little bit rotated. But, you know, these are just little things at this point. Overall, that case looks great. I mean, if this was one of my first cases, I'd be thrilled. But you guys see how efficient the brackets with the aligners were? Because remember the last case at 15 months, we were still trying to get those lower front teeth straight, and it was less crowded. This one at 15 months, it's basically done, and everything got corrected. We just got some little things to keep tweaking. So there you are, start versus 15 months. And the cool thing is the patient only had the aligners in the mouth. You know, I mean, the braces were only there for 4 months, and then a month break, and then into aligners for 10 months. Look at that one. So you see the torque problem? See, if we were doing brackets, that tooth would have the root more labial at this point because the brackets do a better job of torquing. So when that tooth was blocked out to the lingual, that root was placed in the palate. And we were able to drag that crown into alignment with those wires, but then we didn't stay in rectangular wire, so we weren't able to really get the root to come out. And then the aligner, it's harder for the aligner to do that. So that's one of the things I see here is that tooth needs more labial root torque, or more movement of the labial root. And it's tough with an aligner. But look at the lowers. See, the lowers, even though those crowns are blocked out, the bone down there is much thinner from buccal to lingual. So that apex really can't be that far from its ideal position because it just doesn't have a lot of bone to move around in. So it's really just the crown that's blocked out. And once the crown gets in the right position, those lower incisors all look really good. But the upper, you've got all that bone. So when that tooth is blocked out, the apex is actually pretty out of position. So we can move the crown into position, but that root has got a ways to go to get into position. So on this one, I'm not sure, I didn't really look too closely at the setup, but if I was doing this setup for the aligners, I would want the lower incisors to just look ideal, like they do here. But the upper that came from way back there, I would want that one to finish looking like the root was too far to the labial. I would overcorrect the torque on that tooth. So it would look a little bit uglier in the setup because it would look like this tooth was kind of having its root stick too far out to the labial with its crown kind of tipped a little bit too far back lingual. But that would be my overcorrection with the plastic, the over-engineering to try to get that root to come out since we switched over to aligners. So you guys see the difference. So when I talk about the strengths of aligners versus brackets, it kind of makes sense when you see it in the case, huh? And you're like, oh yeah, I mean, look at what this can do versus what that can do. Look at where this one's strong, where that one's weak. And I guess we stopped here. I actually do have more records on this case, but they weren't any more exciting. Like this was the bang for the buck right here. They did 2 more revisions after this and spent about another 6 months in treatment, and nothing really got much better. It looked about the same. In fact, the lower incisors got a little bit of relapse. So just a couple more slides to finish up. If you have to go, I know one of you needs to go at 4. I think Dr. Park, you said you need to go. You guys can go when you want. But let's talk about kids for just a minute, because that's a really exciting part of coming to these courses is learning kid ortho. And some practices don't see kids. Do you guys all see kids? No, not really. Some of you do. I saw, just because I was where I practiced in San Clemente and because I'm young, like I had a lot of families come in. And so I did a lot of interceptive ortho, you know, evaluating kids when they're 6, 7, 8 years old and deciding whether we could wait until they were older or whether there were things we needed to fix now. And that was definitely something we didn't learn in dental school. So when parents are like, does my son need ortho? I'm like, I don't know what I'm looking at besides crowded teeth. And there are definitely things that we want to intercept as early as possible. Like, for example, we talked about that crossbite. If you see a kid who's got a crossbite problem, and you can tell that they're functioning with their jaw to one side because they're accommodating this insufficient maxillary width, the sooner you get them with an expander so that they can expand the upper so that their lower will fit into the upper, their face can develop straight as they go through development. Another one is habits. If you can see that the kid like, hey, okay, this time they came in and the front teeth aren't in all the way, maybe they're still erupting. But 6 months later they come in, they're still not in all the way, they're thumb sucking or they're tongue thrusting or there's some habit that's keeping their teeth from erupting. And I can do sometimes nothing more than just put a little tongue tamer, it's called, little cleats, little pokey things on the back of their upper incisors, nothing else. Just take a picture, put some little cleats on there, they come back 6 months later, their bite's normal, their function's normal. And I take them off. Didn't even put braces, didn't put aligners, didn't put anything on there. Just got rid of the habit. If they're 6 years old and they're sucking their thumb, they're not going to stop sucking their thumb at 6 months. So I'm like, you know, encourage them. There's some really bad tasting fingernail polish you can put on. You can put a sock on their hand at night. You can try to do stuff, but really until they want to stop sucking their thumb, you're really not going to be very successful. When they finally do, there's a lot of cool things we can use that we teach. One of them is really interesting. It's called the bluegrass appliance. It's this little bar on the roof of the mouth that's either got beads or a roller on it. And it's crazy. The guy that invented it is an orthodontist that was into horses. And horses, when they're feeling anxious or they're just restless, they put a little copper tubing on their bit. And the horse will sit and play with the copper tubing, and it calms them down. And the doctor was like, I wonder if people who thumb suck would like playing with little things. So he made a little thing, looks like a little wire across the roof of the mouth, but it has a little thing to play with. And patients enjoy playing with that enough that they stop sucking their thumb because they would rather play with this thing with their tongue. And so he uses that until the bite gets fixed and then takes that out. So there's cool stuff that we learn in this early interceptive, but fixing things like open bites, habits, cross bites, things like if we see that they're going to be a class 3 case, putting things like a little lower lingual arch in there so that when they lose that primary molar, their molars don't shift forward into more class 3 position. There's really important things that we can do early on. And then there's other things where you're like, there's a little bit of crowding, but there's not that big of a deal. Let's wait till they're older. Let's not burn them out. I don't treat anybody earlier than 6, really, just because compliance and trying to get scans and just the whole bit. But at 6, they're getting their, what I really want to see is I want to see them when they have their 6-year molars in all the way, and I want to see upper and lower incisors in. So at the point where they have primary canines, first molars and second molars are all primary, but they've got permanent incisors and permanent first molars, you can really see a lot of how it's all going to work out, and you can do a lot at that point. So we can affect deep bites and open bites, we can affect transverse problems, we can affect big anterior posterior problems, all the things that, like, if we can fix that early, they'll develop properly. Sometimes they don't even need phase 2 if we do a good job in phase 1. So we're looking for these severe problems early, give them better function, help them develop properly, create proper space for the teeth to erupt. Sometimes they've got narrow arches, blocked out teeth, they don't breathe through their nose, helping them establish nose breathing at an early age. Trying to do all that we can to avoid having to extract teeth later. It's not always possible, but a lot of times we can. So this lower lingual arch, if the patient's crowded and they're class 1, and we put this in there, we picked up all this extra space to align their front teeth into because we didn't let that molar shift forward. By the way, it's interesting. I used to think that the fact that this little guy was resting on the back of those incisors is what kept these molars from coming forward. But it turns out that those incisors are very happy to tip forward. So this really doesn't do anything to hold these back there. What's holding them back there is the fact that we've fixed the width of these teeth. And if these teeth move forward, do you see how the arch gets more narrow as it goes forward? So for this tooth to come forward, it also has to get closer to the other tooth. So it's actually holding the width is what keeps them from coming forward. It's not this. That's just there to get out of the way of the tongue. Because in the roof of the mouth, you see the transpalatal arch that goes across the roof of the mouth? The only reason why we don't do that in the lower is because the tongue is there, so we have to go around the tongue. But that can really save extractions. If we put this in a case where we just see that they're crowded, and we put this in, and then all that extra space right here that we get from the size difference between the baby molar and the adult tooth, all the crowding can align into that space instead of having to result in tooth extraction. And then class 3 cases, if we see that they're tending to be class 3, that's a huge deal right there. Keeping those molars from shifting more class 3 is a big deal. We use things called utility arches. So deep bite cases will make it so that when this wires out, it's like way up here, and we have to pull it down into the braces, and then that starts to actually lift those teeth up early. So gingival display and deep bites, we can control early when all we're doing is skipping all the baby teeth, and we're just engaging that molar and those front 4 teeth. And you can do the same thing with aligners too, In fact, we'll be teaching in our seminars phase 1 treatment in aligners as well, because there's a lot you can do with aligners in phase 1. So there's the upper TPA that's maintaining. So if we go and do upper arch expansion, we do a lot of this stuff. There's a lot of different expanders out there, but this is the best one when you actually, so there's a difference between teeth needing to expand dentally. So we're just moving the teeth within the dental alveolar process versus actually needing a wider maxilla. If we need a wider maxilla because the maxilla is constricted and they're still a teenager or younger, we can take that mid-palatal suture and actually open it and grow new bone in there so that the maxilla is wider than it used to be. That's different than just moving teeth. We want bony expansion. So when we use this guy, this bonded rapid palatal expander, by grabbing all of these teeth, we make sure that those teeth aren't just tipping, and that when we go and start cranking this, we're actually splitting the suture and getting the bone to move out rather than just tipping the teeth out. And you'll actually see a big gap open up between these 2 front teeth because you're actually moving the 2 halves of the maxilla away from each other. Once they're in their 20s and later, that can't happen anymore. Then all we can do is just dental expansion, and that we're limited. So we got to get on these early. Okay, so this is a bonded rapid palatal expander. And after we do that, we put this TPA in to maintain what we did so that it doesn't collapse back in while that new bone will grow into that space. We do use some headgear. This is another one that's a really important one. This is a class 3 headgear. And patients don't wear this except when they go to bed at night. But if you have a class 3 case where some of the class 3 is coming from a deficient maxilla, so in the anterior posterior, the maxilla is underdeveloped, this pulls the maxilla forward to keep up with the mandible. And doing that can actually prevent having to have surgery later. And you can even do this with just aligners. You can wear an aligner with a reverse headgear to keep that maxilla coming forward. And then sometimes we'll wear a cervical headgear to restrain the maxilla and let the jaw catch up to it. Keep in touch. Yeah. I think that it's being recorded, so talk to Morgan, and once they process it, then they'll be able to send the video out. We don't actually distribute the actual PowerPoint. I wonder for this, because normally what they do, though, is in SmileStream, they'll give you access to view it, but you won't be able to actually download the PowerPoint, because I guess we had people that took advantage of that at one point. But reach out to Morgan, and he'll get you what you need. Nice to meet you. There's that bluegrass appliance with the little tongue roller. Dr. Park, nice to meet you. And then these are those lingual cleats to keep people from sticking their tongue, from those tongue habits. So just a little taster of some of the stuff we do in phase 1 ortho, but we spend a whole seminar, a whole 4 days going through diagnosing and treating mixed dentition phase 1 stuff, and I love it. For me, doing cosmetic work on kids, on 8, 9, 10, 11, 12-year-olds, is just super fun. I just really love it. And especially when they end up in phase 2 with not a lot that needs to be done, and you're like, wow, this case came out so well because we were able to get to that early. And the other cool thing is a lot of times patients will go into an orthodontist. See if I can get this chair to not sink. People go into an orthodontist when they're 8, 9, 10 because their friends are. And the orthodontist wants to keep that case. So they'll put brackets on just because. And then that kid ends up wearing brackets for a couple years just because the orthodontist wanted to put a little flag on their head and say, that patient's in my practice. Whereas for me, the family's already in the practice, so I don't really have any reason to do any ortho unless it's really indicated. So I feel like a lot less patients actually get phase 1 treatment in my office because they don't get it unless they really need it. If I look at them, I'm like, yeah, the teeth aren't perfectly straight, but we don't need them perfectly straight. Let's wait and do it later. Then I just am not motivated to do phase 1 treatment unless there's really a reason to do it. Whereas a lot of ortho, in ortho practices, a lot of phase 1 gets done that really wasn't necessary. So this is also, we're just going to do a little taste of this one, this pre-restorative ortho stuff, but I love this. I think that if we don't do ortho in our practices, there's probably a lot of times where you guys have seen, like, ortho could help this case, but I really don't want to send them to an orthodontist and, like, lose the case for 2 years. And I don't know how much they're going to charge. Like, we'll just do the restorative. But when you do the ortho too, it just doesn't feel like the patient goes away, and who knows when we're going to get to do those restorations. When you do the ortho, you're completely in charge, and you're like, hey, this is what our goal is. We're going to do the ortho to get to this point. I get to control how much we charge for the ortho. I get to set it up exactly the way I want it. Doing restorative work combined with being the one that does the ortho is just really rewarding, and you're completely in control of that, and I like it a lot. So we'll look at a case just as an example. This is a 60-year-old gentleman. Kind of, you guys have seen this one where, like, look at, he's all business, right? Like, he's got the earpiece in. What do they call that thing? The jaw something? There was a name for that little thing right there. Do you guys remember? What was the brand that made those things? It was like, I don't remember. But people would have it in all the time. Like they walk around, you're like, are you on the phone? He's like, no, it's just there in case I have to answer a phone call. You're like, are you really that busy and important, like holy cow. But it doesn't even take him out for the records. So, he's got his game face on. But my guess is he's like, he got divorced. We'll just make it up. He's put his whole life into his practice. He's getting divorced. But he's coming up on retirement. He's got plenty of money. And now he wants to look good, to go into retirement, go find a new wife. I don't know what the story is. Actually, he came in because there was he was having pain. You see the swelling up here? He was having pain, and there's a tooth that's fractured, and he's going to have to lose that tooth. Let me see if I can show it. Yeah, right here. So there's a perforation, there's a swelling, there's abscess. So that tooth's got to come out. So what's the next step after that tooth comes out? Probably an implant, right? Are we going to do an implant on that? Like that needs ortho first, clearly, right? Because if you just pull this tooth out and put an implant in, your implant's going to be at completely the wrong angulation, wrong position to fix that. So he has to have ortho first. So, he's already made plans. See the posterior teeth? Have you guys ever had patients do this where they're like, as they do those crowns, they're like, well, eventually I want all my teeth to be really white. So let's start doing all of our crowns really white, and eventually we'll get to all the front teeth and make them all really white. So he's already got a plan for cosmetic work. He already picked the white shade instead of the yellow shade back there. I had this one gal come in once. She was like the most eccentric, fun lady, and she was like in her, I don't know, like 75, something like that. And she wanted all of her front teeth done. And she's like, I want the whitest shade that you have. And I was like, no, you don't. And she's like, no, really, I want the whitest shade that you have. And I was like, look, the whitest shade I have looks awful. I hate it. I'm like, just pick a shade that looks nice, that looks like, yes, they're white, but they're not like crazy. And she's like, nope, I want the whitest one you have. And I was like, if I give you the whitest teeth I have, you will never tell anybody where you got your teeth done, and I'll tell you that I hate it every time I see you. And she's like, I don't care. I want them whitest. So we did like the whitest shade on the shade guide, and she loved it. And every time she came in, she was like, I love my teeth. And I was like, I hate it. Stop it. Don't show me those. They're awful. And we had this little ongoing thing for years where I told her how awful her teeth looked, and she told me how much she loved them. So it was fun. So what are the problems he's got here? He's got a class 3 occlusion. We've seen a lot of class 3 in this seminar today, which is not the most common. Usually we see class 2. That's the most common malocclusion. So we've got negative anterior overjet, a little bit of a deep bite on those teeth right there. His upper arch has got some crowding. Not as much as his lower arch does, though. And he's going to lose this tooth, 2-2, due to the post-perforation. And we got to do ortho first, because you can't just go throw an implant in that position with this bite. So here he is, partway through treatment. See how not being able to see the upper incisors makes you look old? Look at how worn down. Those teeth have been on the back side of those lower incisors, just getting the heck beat out of them. It's probably why that tooth finally broke, or that post really wasn't that great of a post, but those teeth have been getting beat up. This was being treated with aligners, a little bit older case, but it's being treated with aligners. Maintaining and keeping a space here. And you guys know with aligners, we can put a little pontic there, so there's a space for a tooth, and then you just paint the aligner so it looks like there's a tooth while they're wearing all this. But you get to a point during treatment where the bone can actually tolerate an implant placement. Okay, so the infection's been healed, everything's looking healthy. And what's cool is if he had actually had a bony defect, you can go in and actually extrude the tooth, put braces on, and you can actually extrude the tooth before you extract it, and you just keep grinding it down, and you can take a pretty significant bone defect and pull the bone down and pull the tissue down so that when you finally extract that tooth, you've got a beautiful implant site. No, you have to clear the infection. Yeah, so they'd have to do, some antibiotics and maybe even get it there and whatever they have to do to get rid of the infection. But you can, but the tooth's hopeless, you have to extract the tooth. You can pull that tooth all the way down. Or maybe you have a tooth where it's not hopeless, but you don't have good ferrule effect, you don't have enough height of the crown, And you can also extrude a tooth down enough to be able to get proper ferrule effect and stuff like that. So you can actually use ortho extrusion to restore an unrestorable tooth or to set up a really good implant site. We've also done things like, let's say you're missing a first molar, and you know how the bone will get really narrow in that spot because they've been missing it for years? And we'll take a bicuspid and we'll distalize the bicuspid with braces, and where there was no bone, remember how it builds bone wherever you're moving the tooth? You can actually move that tooth distal to the second molar and then leave this nice big area where you have all this brand new bone that you just built to be able to go and put an implant in. So there's a lot of cool things you can do orthodontically to set cases up for restorative success. But in this case, at this point, this site was ready. We're not done with the ortho yet, but at least the implant can go in. And there's even papers out there that show that, like, if you have to graft an area or if you need to place the implant, that the success of those is higher when you do an ortho in the area because you've activated all that cellular activity. So all the osteoblastic, osteoclastic activity actually helps a bone graft to work better, a ridge augmentation to work better, an implant to take better. So here he is, still mid-ortho. You can see his profile is looking better. If you go back to the start and look at his starting profile, you can see that as those upper teeth are coming forward, he's getting a little, whoops, wrong way. He's getting a little bit more upper lip support. Okay, so there's the implant placed. All these teeth are going to get restored eventually. See those gingival, looks like at some point that gingival restoration fell out. But we're creating good anterior overjet for the restoration, so you can see that there's lower IPR happening to get those lower crowded teeth straightened. You can even see how much more narrow they are. But then also in the upper, since we're restoring the whole thing, see how they're creating space? There's a space right there. So if you're going to restore the upper, you can get the overjet proper by leaving some spaces in the upper because you're just going to put restorations, and then that lets you bring these lowers back and get proper overjet. So what was happening here? It says, yeah, see how these gingival edges don't line up properly? I don't think he smiles high enough to be able to see that, but if they did, and you're going to restore all this, it's better to get the gingival height correct and then let your restorations fix all the worn incisal edges. So look at the difference of where that gingival architecture was here versus here. That came from changing the torque of that tooth. You see how it went from being tipped back to being tipped forward? And so the attachment went up on that. And if this patient had a real high smile, you could even continue to intrude this tooth until you get these two gingival heights exactly the same. And who cares about this incisal edge, because you're going to restore all that with your final restoration. So here he was with temporaries. Got the earpiece out, starting to get a little tanner. Doesn't look as stressed from work anymore. So uppers are temporized. So there's what you went from start to temporaries. And then this was his final restorations. Look, he looks like he's out on the golf course now all the time. He's all tan. His face is looking a lot more relaxed. He looks like he's retired. Look at how much the whitening. I did not imagine that those lower teeth would whiten that much. That's a crazy amount of whitening. It's looking pretty good, though. I mean, doesn't he look like an overworked guy that now he looks like he's in retirement and he's dating somebody new, all tanned? So funny. But there's final restorations. Probably the lowers will maybe eventually get veneered. I don't know, the whitening looks pretty good. That's cool, though. Do all that in your office instead of refer this out and have a lot of people working on it. You know, you get to capture all this in your own office. Maybe you send that out for the implant placement, or maybe you place that implant yourself. But you get to be in control of all the timing and everything. And, you know, and I tell doctors too, even the ones who don't do ortho, I'm like, When you do this multidisciplinary dentistry, you know, like say you're doing this and you have a periodontist involved, you have an oral surgeon involved, like you're doing all this stuff. Aren't you supposed to be the quarterback? Aren't you the one who's supposed to be determining like what we do, when, and whatever? But you're like, how do you be the quarterback if you don't know ortho? So even if you don't do ortho, just learning ortho, just having that app that I was showing you so that you're like, hey, I at least know the plays. I have a playbook. And I can at least run a few plays here and see which one's going to work best so that I'm the quarterback and I'm guiding my multidisciplinary team. And we can look at it together and make decisions together. I mean, knowing ortho is way better than just sending it to the orthodontist and be like, this case needs ortho. And then they come back like, well, how much space do you want for this and when for this? You're like, I don't know. Like, just do the ortho. Just like whatever you think needs to be done. I don't know what can be done. But when you know ortho, even if you don't do it, like you now can talk and go like, well, this is what I want. You can do this, right? You know, the simulation shows this. Maybe can you do that? Look at this simulation. Can you do that? Yeah, I can do that. Okay, let's do that. So in summary, ortho enhances your entire practice. I would say that almost every patient that comes in your door would benefit from ortho. There's a huge amount of opportunity there. Most of the ortho cases go undiagnosed and untreated just because we don't know ortho. So if we look at our patient base, our adult patient base, there's a lot of orthodontic conditions there that could be benefit to the patient, not just aesthetic. And it just never gets done, never gets diagnosed, never gets talked about. They don't get sent to the orthodontist. Unlike most areas of dentistry, orthodontic treatment is something your patients actually want. Nobody wants a crown. Nobody wants a root canal. Kids especially don't want anything that you have. But ortho is something that they all want. Not only that, every parent plans on spending a lot of money on their kids' ortho. Ortho cases regularly lead to more cosmetic treatments, more implants, more restorative work, more perio treatment, any other procedures. You become like the hub of everything your patients need. By investing in orthodontics, your patients are investing in their smile, and they'll be more willing to take on other procedures in the future to maintain their new smile. I found that my patients who straighten their teeth are way more invested in their oral health over the years. Like they feel like they did a good job of doing something, and now they're like, they want to come in for regular checkups, they want to keep their teeth whitened, they want to keep everything well maintained. And then ortho patients go around talking about their experiences. You know, you've transformed them. If you do a root canal on somebody, they don't usually go around and tell everybody about it. But you change somebody's life with ortho, and they're out there talking about you to other people. It leads to a lot of restorations. A lot of new referrals. So I just want to invite you guys to consider, if you haven't already, like come and learn this stuff. Come and make this a full pursuit instead of just a one-day adventure. Come actually make this a part of your practice. And I know it's like timing, you know, maybe this is or isn't the right time for you, but you guys are all young. Like say, hey, at some point, this is something I really want to do. I really want to make this like a big part of my practice. My son, who's in dental school right now, he's only first year, but he's really thinking like, do I want to go into ortho and commit fully to ortho, or do I want to do general dentistry with lots of ortho? Because I've talked to him so much about all the things that I enjoy doing as a general dentist. Like I do like doing all the procedures, and I maybe wouldn't enjoy just doing only ortho. But then when I look at what happened to my neck and my body, I'm like, maybe it would have been better to just do ortho so I wasn't like this all the time over patients. But you know, general dentistry is awesome. And of everything that I could have ever done to increase the service in my practice, the ortho was by far the best thing I ever invested in. And just from enjoying my career to patient satisfaction to staff satisfaction, we all get bored at work. You know, when you're new, maybe not, but eventually it's like more fillings, more fillings, more fillings, more crowns. It's just, and having something like ortho is just fun, it's challenging, it's something new, it's adventurous. And I think we went over pretty well the different learning ways that we have. This new course that we're doing, you know, it's brackets and aligners all the way through. It's all new cases. That one I just showed you was one of the older cases from the old curriculum, and you can see the difference between the older cases and our newer cases where we have way better new photos, way better like scans to look at. Looking at older cases are interesting, but it's like, you know, so our whole thing is in the process of being rewritten right now. Using this ortho simulation app, you'll really learn how to master that app so that you know how to use that on your patients. We even have something that we teach called dental monitoring. So a lot of our aligner patients, well, doctors who use dental monitoring, have you guys ever heard of dental monitoring? Probably not. It's using the phone. So you imagine your patient comes in for an aligner and you give them all their aligners and you go, we will stay in contact with you. We'll be monitoring this remotely. And you only ever have to come to the practice when something's needed to be done. Because your patients actually don't want to take time off of work and out of school to come. Like they like you, but they actually don't want to come all the time. And when we're in ortho and they have to come every month, it's a lot. And so with dental monitoring, it's a service where they get this little scan box that they put their phone in. And the phone has an app that's connected to an app in your office. And every week the patient scans. And the AI is evaluating the fit of their aligners and telling if they can move to the next aligner, if they have to stay in this aligner longer. And so instead of having a set schedule where you change every week or every 2 weeks, it scans every week, but it tells you when the teeth have moved into that aligner before you can move to the next one. So it makes them have to be accountable to a computer instead of, to you or whatever. And so treatment goes well because they have to scan and they have to have the AI say, it looks good, you can go to the next one. But literally, some patients don't come back for a year. But you're in constant communication, you get to see everything, and everything is being monitored, but they don't actually have to come in. And so every time, I think one of our doctors figured out, we had a guy that came back and he had learned how to do ortho, and then he said that he stopped doing ortho because it was just too expensive. He's like, I figured out that every time a patient comes in, it costs me $200. Between his staff time, lost production doing something else, sterilizing the room again. He's like, it cost me about $200, $230 every time a patient walks in my door. So if I'm not getting more than $230 out of the appointment, I'm losing money when somebody walks in. And then he found out about this dental monitoring, and now he's fully back into ortho because he's able to do all these ortho cases without having to have constant patients coming in all the time. So it's just another thing that we teach in our series towards the end to enhance your profitability. Initially you do have to see them all the time so you know what's happening, but once you master it, you can do a lot of remote monitoring for your patients, and that's what they prefer anyway. I mean, look, people don't even go buy food anymore. Are you guys Uber Eats? And I still have never ordered food to my door besides pizza when my kids were little. But like our neighbors, like there's always somebody dropping off food at their house. I'm like, we don't even want to go. We use Amazon to get all of our stuff at the house. We don't even want to go get food. We just have that sent to our house. Like people really don't want to go anywhere. And so if you can do ortho without them having to come into the practice, it's pretty cool. We talk a lot about hybrid cases, pre-restorative, multidisciplinary, mixed dentition, lots of cool stuff. So I already kind of went over the curriculum of what we do at each different seminar with you guys and kind of how we progress through the seminars. And then Morgan talked about the free tuition, free lifetime retakes. And we talked about the live series versus the hybrid where you do some online and some live. And then he pointed out the different locations. And then for your friends too, like if they want to come, like let's say you sign up for the Orange County one and start May 15th, you can bring a friend. They can come for the first day for free if they want to. So if they miss this, but they're like, I am interested, but I'm not fully committed, they can come one day free anywhere. You guys might want to take a picture of that screen. Let me move the cursor out of the way. It's a YouTube channel where you can go find 6 free aligner case studies. So like it's 3 hours per case. We only spent maybe 45 minutes to an hour on a case today. But in this one, Dr. McGann does half of them and I do half of them, and we spend like 3 hours talking about these aligner cases and everything that went on and how to diagnose and all that stuff. Those are free if you want to go watch those. And then again, there's a lot of benefits to learning